Hi, Tushar. Muted. Muted, Tushar.
Very good morning, sir.
Hi, Kem Show. Thanks for sharing, Tushar.
Not at all, sir. Thank you for coming on board as usual.
And Tushar, how long is the Q&A? It won't go on forever, na, Tushar?
The Q&A with you is
Yeah.
being conducted by me, not
Lovely.
by the others.
Yeah.
You give me a time limit, that's all.
Half an hour or so.
30 minutes is perfect. And
Lovely.
how much is your talk on? How long is your talk?
It's about 30-40 minutes as well, Tushar.
So total 1 hour plus.
Yeah, and
a little bit.
At the end of your Q&A, if you just ask for any ending comments I've got a few things I want to say, Tushar.
Oh, wonderful.
Yeah, lovely.
I'll do that.
Okay, lovely.
Live daba, live daba.
Half an hour or so.
Yeah.
30 minutes is perfect. And how much is your talk on?
Sir, kindly mute. We are live.
Sure.
Anil,
Yes, Dr. Kamlesh.
shall I start?
Yes.
Hello, good morning, friends and colleagues. I welcome you all today in our first webinar in 2022 on Omicron update. We were successful in holding hybrid CMEs last 2 months, that is in November and December 21, in physical form at Sir H.N. Reliance Hospital and on the YouTube platform. But unfortunately, because of the pandemic scenario, we are forced to revert back to the webinar form. Today's subject is very relevant as we are in the midst of a tsunami of Omicron engulfing us. Today we have very two eminent speakers addressing us. Dr. Jiren Urwadia, whose name needs no introduction. He is internationally known chest physician. He has been in forefront of treating as well as educating us all since the initiation of this pandemic. Dr. Tushar Shah, who is a teacher par excellence and regularly guiding us, all the physicians in the management of COVID with his rich experience. Today, with sudden explosion of Omicron and its variants, various questions crop up not only in the minds of general public, but us physicians. Is this mild? If the cases will increase, will the demand for oxygen and hospitalization will increase? Why, despite two vaccines and a past attack of COVID, I have again tested positive? How much more the booster will protect me? Which booster to take? Either the other one or the same one? What should be the interval between the two boosters? Should all 60 plus and with comorbidities irrespectively take monoclonal antibodies? So as you all must be aware that Dr. Udvatia and Dr. Tushar Shah will throw a light on this case. We at the Bombay Seaboard Medical Association are regularly holding CME since last 40 years. Over the period of time, our CMEs have been very popular and have been very well attended by doctors, not only from all over Mumbai, but from the periphery. Our clinical secretaries and the whole team have worked very hard to arrange the talks on vastly different subjects with renowned and reputed experts and consultants sharing their knowledge. I am thankful to Dr. Anil Mehta, Dr. Jawar Mukhtiar for organizing this webinar. I am very thankful to Dr. Jarir Udwadia and Dr. Tushar Shah, who despite their very busy schedule, have granted us their time. We are fortunate to be joined by Bombay Medical Union, Sir H.N. Reliance Foundation Hospital, GPA, FFAPI, the Bombay A Ward and D Ward Medical Associations, and Jain Doctors. I am very thankful to all the panelists, Dr. Vijaybai Khambati, our past president, Dr. Asaben Vasani, president of the BMU, Dr. Rusin Mehta, Dr. N.K. Kumar, Dr. Sunita Manglik, Dr. Manoj Malkan, Dr. Janak Shah, and Dr. Bhairavi Shukla. I now hand over to Dr. Anil Mehta to take over the proceedings.
Welcome to the Bombay Seaboard Medical Association CME on the most relevant need of the hour webinar, Omicron update, beginning of the end or end of the beginning. At the outset, like Dr. Kamlesh just mentioned, I would like to thank the Corona warriors, the speaker of the day, Dr. Jarir Udwadia, and the moderator, Dr. Tushar Shah, who have come forward at this crucial moment to iron out the myths around this mysterious disease and bring forward the facts. I also welcome the viewers to post their questions, which will be addressed by the eminent panel of physicians at the end of the session. Dr. Jarir Udwadia, as Dr. Kamlesh Shah did mention here, a well-known physician across India, does not need any formal introduction. But today, I take this opportunity to focus and highlight his COVID-related activities. Right from the onset of COVID pandemic in March 2020 onwards, Dr. Udwadia has been a crusader in this war against pandemic. He has managed corona patients in 3 hospitals in Mumbai, that is Bridge Candy, Parsi General, and Hinduja Hospital, as well as across the entire country through video consultations. He also trained many resident doctors who are working as a part of his team to learn and understand this new and perplexing disease. He has carried out innumerable, widely viewed lectures and Zoom meetings to educate medical colleagues and the general public across the country. To make a special mention here, a WHO meeting with Chief Scientific Advisor, none other than Soumya Swaminathan, and a guest session at the prestigious CROI USA conference. Out of his 200 plus PubMed index publications, there have been 30 plus publications are on COVID, and they are published in the most prestigious medical journals, including Lancet, New England Journal of Medicine, and British Medical Journal. He is on the National Task Force elected by the Supreme Court, and also the COVID Task Force set up in Maharashtra to address very crucial COVID issues like oxygen, drugs, and vaccinations. I also take this opportunity to introduce today's moderator, Dr. Tushar Shah, a well-known physician and master educationist. One of his areas of interest is empowering the family physicians. Since March 2020, he has been teaching outpatient COVID management to a group of 2,000 odd physicians. The evidence-based teaching has been widely admired amongst the entire medical fraternity. Dr. Tushar Shah has now personally treated over 20,000 plus patients and over 1,000 indoor patients of COVID. He hopes to dedicate the rest of his career to teaching medicine. So may I call upon Dr. Tushar Shah to open the session, please?
Thank you so much, Dr. Anil, Dr. Kamlesh. Without wasting time, I would like to invite Dr. Zarir. Dr. Zarir has been, of course, the beacon of light in a lot of murky atmosphere of therapeutics. And we have been guided by you, sir. And it has been my privilege to hand your teachings down to other people. Dr. Zarir, can you please start the talk?
I hope you can see and hear me, Tushar.
Hear you,
Yes,
sir.
sir.
I can hear you well.
And you can see the slides?
Yes, sir.
Lovely. So thank you very much, Tushar, for that kind introduction. Anil, you too, and Kamlesh. Our world has been battered now by 2 years of pandemic, as you all know. We have all vacillated between hope and despair. Just when we were exultant that the ferocious tide of Delta seemed to be receding, we have now had another new variant, Omicron, which is going to be the focus of today's meeting. And at the start of this new year, we find ourselves again at a very strange and different place from where we were in 2020 when the pandemic began. This virus clearly has a lot of unfinished business with us. It's not finished with us yet. And we can only continue to hope that the might of science will help us at least keep abreast of it. Now, these are the origins. On November 25th, 2021, that was exactly 23 months, 260 million cases and 5.2 million deaths into the pandemic, so-called patient zero was infected with a new variant of concern, and this was reported from Botswana. Now, this was despite the worldwide rollout of vaccines, and vaccine euphoria was quickly punctured by variant terror. This was the fifth SARS-CoV-2 variant to have surfaced, and I like to think each variant is like a suspect in a detective novel. Each has its own personality, and we will find more about the personality of Omicron today, hopefully. It was named so after the 15th letter of the Greek alphabet. They skipped the letter Xi, Xi, because of its connotations with the Chinese leader who would not have been too happy to have a lethal virus named after him. We shouldn't have been surprised about this variant, though a lot of people were taken by surprise. And I'm always amused by pundits who try and make projections. Oh, the wave is over, or we won't have any more Omicron. Let's be honest and say we just don't know, but we should expect the worst. Well, this genome, SARS-CoV-2, is one of the largest of RNA viruses. It has 30,000 nucleotides. Therefore, mutations are bound to occur. Indeed, because it has a proofreader, an exon enzyme proofreader, the mutation rates of SARS-CoV-2 are, at least mercifully, just half that of influenza and a quarter that of the HIV virus. So why the surprise? It's the nature of all viruses to mutate over time. The only certainty about COVID-19 is that mutations are, unfortunately, inevitable. Most do not matter. But when the virus acquires a mutation that gives it an advantage, that's when it matters hugely, as we shall see. Then this mutated strain will transmit better than the original, for it's in the interest of the virus to keep propagating, and it becomes the dominant strain. And essentially, this is just Darwinian evolution, which we have all evolved from over tens of thousands of years, speeded up by the virus into a period of weeks or months. These were the origins. The first ominous statement from Shikulile Moyo, the lab director from Botswana Harvard AIDS Institute, who said, and I quote, "We see something very strange. Patterns of mutations we've never seen before in 4 of the 95 COVID positive swabs randomly selected for genome sequencing." Like any good scientist, he double and triple checks for lab contamination, because that is the bugbear of any PCR test or any genomic test. And then again, responsibly and promptly uploads his data to GISAID, which is the global repository encouraging everyone to online submit all the strains that they have sequenced. South Africa, a few days later, reports something very similar, but this is a clinical observation now, a rapid rise in COVID cases in the Gauteng province. And you can see from this map that Botswana and South Africa, of course, share a very porous border. And again, the remarkable Professor Tulio de Oliveira from the Nelson Mandela School in South Africa attributes this surge in the Gauteng province to the appearance of this hyper-mutated new variant. And remember, Gauteng province is home to Joburg and many other very, very populous cities in South Africa. Now let's pause for a moment and ask ourselves critically, would we have ever moved with this speed in our country? This transparency, this efficiency, this speed, within a few days of noticing a new strain, would we have reported it as we did? I'm not going to answer this question, but leave it to you to figure out the answer. And these are the different clades of the SARS-CoV-2 virus. Scientists call this B.1.1.529. The WHO, within a few days, this time the WHO didn't take any chances. They got it right. And just 3 days after its reporting, labeled it a variant of concern, which is the most exalted title, I guess, a virus can aspire to. It was the 5th after Alpha, Beta, Gamma, and Delta. And since less than 2 months it has been detected already, and this is from the New York Times, in 140 countries. And a few days ago was reported in a remote Antarctic station, which is somewhere down here. So once a virus takes off, there is no stopping it, as is apparent from this map, which will soon be filled in with orange. And the global daily average cases these days, number of people infected is 1.6 million. Let me repeat that. 1.6 million cases are infected every day, which in my mind must be making this the most infectious respiratory virus the world has ever encountered. And don't shoot the messenger. It's by no means certain that Omicron originated in South Africa and Botswana. I would say it was just that the excellent sequencing labs were the first to pick it up. And I'd like to say here that they are really pioneers in the field, and I'm including among any countries, Europe and America included, in their genotypic strength. For tuberculosis as well, they are really the pioneers. So they have an amazingly sound genetic network. And there was clear evidence that Omicron was spreading in Europe before the first South Africa cases. Dutch authorities found cases 11 days prior. Scotland reported cases 9 days before it was actually reported by Botswana, none of whom had a travel history. And, the whole point of mutations is that they can start anywhere in the world. They're horribly mobile. Their muscular power, their global reach is just incredible. So I think it is wrong to blame South Africa, Botswana, as many people did. The first Indian case, for example, was a doctor in Karnataka with no history of travel at all. So certainly community transmission was probably ongoing in this country even before South Africa. So a travel ban seems irrational and discriminative in the most. And it was nice to see that the UK and US had lifted their travel bans across all countries, including Africa. And we went, of course, the other extreme and increased our travel bans. It doesn't make sense to do that when you have about 100,000 cases in your own country every day. So as the South African foreign minister said, excellent science should be applauded and not punished. Bans only serve to punish South Africa for its advanced genomic sequencing and its ability to detect new variants quicker. And of course, it's the mutations that have alarmed scientists the most because of the sheer number of them, 50 in all, which make it the most heavily mutated coronavirus ever. But remember, more mutations does not necessarily mean worse. Mutations can sometimes cancel each other out. Sometimes they may give a virus superpower. It's difficult to predict. But what is clear is that Omicron has an ominous number of them, 36 unique spike mutations. And this just shows you the numbers in this diagram here compared to beta 11, alpha 10, delta 9, gamma 12, and Omicron 36. So far more than other strains. And as someone said, these mutations are in a class of their own. And that is the ominous looking spike protein of Omicron. And again, if you compare the number of mutations in red here, in the spike protein area, you can see that they are far, far more than the Delta virus, which preceded it. As Stephen Hoke said, this thing is a Frankenstein mix of all the greatest hits. It just triggered every one of our alarm bells. And that's even more alarming when this quote comes from the head of Moderna, which is supposed to be making the most reliable and solid vaccines that we have today. So let's move on. How fast is it spreading and how infectious is Omicron? Omicron is indeed far more infectious than any other variants. That's clear now. Several of the mutations on Omicron are known to be associated with increased transmissibility. That's what the mutations do. Some of them actually give the virus the advantage of being able to transmit much more easily. How much more? I would say about 5 times more infectious than Delta, which was bad enough, as you know. So Omicron has the potential to spread much faster, infect vastly more people than Delta. It can infect 3 to 5 times as many as we've heard over the same time period, which is a huge evolutionary advantage for the virus, but not for us. And the global spread has been relentless. I mean, I make a slide and it becomes obsolete the next day. In South Africa, it's already the dominant variant within the first 2 weeks. So that's a remarkable speed, a remarkable exponential speed. In the UK, there's been doubling every 2 or 3 days of cases, and it's become the dominant strain. In the US, 75% of all infections, again, the dominant strain, and globally will soon take that position as well. Just some clippings from different news sites. The dominant strain in South Africa. Deaths in the UK could mount to 75,000 by the end of April, doubling every 2 or 3 days. UK Omicron infections could reach 1 million a day in a small country by the end of December. And in January, they already did that in the US. One country, one day, 1 million cases. That is a record of sorts. but records are broken so fast with this virus. What about this country? It has clearly emerged as the dominant strain. Look, Delta was clearly receding. A study from the ICMR found that 84% of samples tested in Delhi were indeed Omicron. So I think it would be reasonable to assume that the vast majority, if not all, new cases you encounter in the present wave are indeed Omicron. And that has great bearing to the treatment you will offer your patient. I've spoken to experts in the field. Dr. Nargish Mistry, who has downloaded huge numbers of Indian samples to the GIZ site, agrees and concurs with me when I say that about 90% of all the strains you will encounter and continue to encounter over the next few weeks will indeed be Omicron. So what about India? We've entered, of course, our third wave as we enter our third year. And the trend is much worse than it was in terms of numbers, at least this time a year ago. On January 7th, 1 year ago, with Delta, we were 18,000 cases a day. Exactly a year later, it's 93,000 new infections, close to 100,000. That was a 732% 14-day change. And the economists call this India's super exponential growth. We do enter, of course, better off in terms of widespread vaccination in the population. Hopefully, we as physicians are more experienced and better prepared and have better infrastructure. I hope we have learned our bitter lessons from Delta. Moving on to the diagnosis, you all know that there are 3 ways to diagnose Omicron. Lateral flow testing, that's the rapid antigen test that we do at home, Rtpcrs, which remain the gold standard, and genotyping, of course, which is something which cannot be used clinically. That's an epidemiological tool, so we leave it out because you cannot give a sample and expect to get a report back on the genotype of your patient sample till at least a few weeks pass. Unfortunately, it takes that long. So let's look at the lateral flow test or the rapid antigen test. This is a very, very murky field. It's a very nebulous area. I have tried to give you my thoughts on this very important area. And believe me, this is going to be the main diagnostic tool as the pandemic advances for all of us, public and doctors. So let me give you my take in just one slide on this very important test. As the pressure for PCR grows, rapid antigen tests will increasingly be resorted to. Whether we want our patients to or not, they will resort to them. They're easy to use. They are cheap. They're self-administered. They're repeatable serially, even every day if you choose. And you can get the result in about 5 or 10 minutes. You must use a quality assured FDA approved kit. There are so many kits out there in the market you can buy from your pharmacy. Make sure it's quality assured because different kits have different sensitivities. Because the Omicron prefers the throat to the nose, throat swabs may have a higher yield than nasal swabs, though we don't as a routine do this. Many people would encourage you to check at home if you are checking it, not just a nose swab, but also a throat swab. This is the bugbear of rapid antigen tests. They have a high false negative rate, and that rate may be especially high for Omicron, as much as 40 to 60%. What do I mean by false negative test? I mean that if your patient tests negative on a home test, a rapid antigen test, he could still very well be infected. If, however, he tests positive, there is no doubt that he is positive. So it's not like people say, oh, it's just the toss of a coin. It does give you much more useful information than that. But because of this high false negative rate, my advice would be that anyone demonstrating symptoms, even remotely like a viral flu, should isolate themselves for 3 to 5 days at least, even if their rapid antigen test is negative. As general practitioners, you know, you are frontline even more than me. You know the number of patients who very irresponsibly come to you saying, doctor, I've got a cough and a cold. These patients shouldn't be seeing you. They should be self-isolating, doing a rapid antigen test and staying at home. Rapid antigen tests will miss infections when the viral load is low. They do not have the crucial multiplying step which PCR tests have. And that is why PCR tests are so much more sensitive. Their sensitivity is close to 90%. But they would still identify the most highly infectious person, the person who would unknowingly spread the virus. And this is a FDA warning saying that antigen tests do still detect the Omicron variant, but may have reduced sensitivity. But as I said, positive is positive. Now that's my own home rapid antigen test when I did it a few days ago because I was feeling a bit under the weather. I think doing your own rapid antigen test before you meet friends, before you socialize, before you meet elders in your family is almost becoming de rigueur, like a dress code at a party. I don't think it's inappropriate to say, do your rapid antigen test before we meet. Of course, remembering that a negative rapid antigen test does not mean that you're not infectious. So there's a huge porous net through which cases will slip through. But every positive rapid antigen test is one public health victory, in my opinion, because it's picked up a case at home that much easier. And of course, remember that PCR tests, again, are just not available in this country. All over the world, even in the UK and US, it takes colleagues from the US tell me 5 days to get back a result, by which time it's worthless. So again, the speed of the rapid antigen test is to its advantage. Now let's look at the Rtpcr, the gold standard test in Omicron. A complete Rtpcr looks at a number of genes. Only a few labs, unfortunately, check all the genes in its Rtpcr. But the S gene target failure, not finding one of the genes, is great indirect evidence, a proxy marker, if you will, of Omicron. And this quirk in its genetic signal has been a big blessing in disguise because it has helped epidemiologists track this pandemic much faster than previous ones. S gene target failure, the S gene not being picked up in a standard PCR test is, I think, indirect and the only quick proxy proof that the patient that you are dealing with is almost certainly a case of Omicron. So this variant is widely detectable in the PCR platforms used in South Africa. Again, there are so many different PCR platforms. Of course, final proof would need confirmation by genomic testing, which is not practical. And the Omicron becomes the first RT-PCR kit approved by ICMR to detect Omicron because it would be looking at this S gene. And I wish more and more manufacturers in this day and age did include this particular gene. Genotyping tests, remain the gold standard. But as I told you, they take far too long to impact individual patient care. And isn't it sad again that India, despite being the second largest country in the world on the basis of its population, and of course we remain second largest in terms of known COVID cases, we have sequenced a mere 0.05% of the collected samples which have been downloaded to Gizaid. And this is an open public access site which you can all log into and see. Let's look at the clinical features. The UK has this wonderful app called the Zoe UK app, and a professor from King's designed it. And each person in the UK is encouraged, even if they're normal, to log in their symptoms. And the top 5 symptoms, as per the Zoe app across the UK, were these. And of course, these are what you as general practitioners will be seeing all the time, especially in winter anyway, even in non-COVID years. They are runny nose, in order, headache, fatigue, which is mild or severe, sneezing, sore throat. The loss of smell and taste, you will all have noticed, are a little less common with Omicron, though they do occur, but nowhere as common as with the original strain of SARS-CoV-2. To this, I perhaps need to add drenching sweats, which some patients have been complaining of. And I'm sure Tushar will take that further in the clinical discussions. So for all practical purposes, Omicron presents as a common cold or flu. It has a shorter incubation period than other versions of SARS-CoV-2, just 3 days as opposed to 5 to 7. And the message is clear to all of you, public and practitioners. If you get flu-like symptoms, assume you have COVID unless proven otherwise. Isolate yourselves from your family, from the public, until you get your test results. Apart from the shorter incubation period, fortunately, it has a much shorter duration of symptoms. So patients often report that they are well again within 3 or 5 days. And therefore, earlier discharge from isolation is possible. 5 days, the CDC says, 7 days, France says. In some hospitals in America, healthcare workers are so strapped that within 2 days of a positive test, if your symptoms are settling, you're told to strap on an N95 and get back to work. And this is the main ray of hope, the only ray of hope I see in this pandemic, in this wave rather, that Omicron is clearly less severe than Delta. And I will back that up with several studies. Hospital admissions were up to 70% less with Omicron than Delta. Having said that, the NHS is still in crisis in the UK, and they're certainly better organized than us. And Omicron is just not the same disease as earlier COVID waves, say many UK scientists, and I would agree with that. It causes milder disease, and we have data from 3 studies, and I will quote 2 of them. It affects younger patients for now at least. They need less hospitalization, less oxygen, less ICU care. And this, to my mind, is the crucial, the million-dollar question. Is this a reflection, this milder course, a reflection of the virus itself being intrinsically milder? Or is the population it affects protected by vaccinations, by past waves of COVID, and therefore immune, and therefore experiencing a milder disease? No one knows the answer to this question, but scientists are feverishly working to find out because it has important implications. But despite the extraordinary spike in cases, deaths from COVID-19 are at their lowest globally. My mind shudders to think what would have happened if Delta had had the increased transmissibility with Omicron has, with its clearly more lethal clinical potential. And global case fatality rates, despite the number of cases increasing, have dropped below 1% for the first time in the pandemic. And I like this quote from Dr. Warner Green, who says the Omicron virus comes with both barrels loaded, high infectivity and the potentiality for immune evasion. And I'll tell you about that shortly. But maybe what it is lacking is its pathogenicity. But there is clearly no cause for complacency. Again, many people or some people say, oh, it's like a flu, why are we worried? I'll tell you why. A virus that transmits much faster, even if it's milder, could lead to many more deaths globally. Look, at simple maths, a small percentage of a huge number is still highly significant. That sheer number could overwhelm health systems. Large numbers of healthcare workers and essential staff are off work and sick. What do I mean by that? I've told you about America, for example. Let me give you 2 examples from the 2 hospitals, 2 of the 3 hospitals I'm working at. The head of nursing at one of the hospitals just messaged me today and said 103 of her nurses are off sick from COVID. Who is going to handle wards? Who is going to look after COVID patients? Who is going to look after dialysis patients, heart patients, tuberculosis patients, cancer care? Everything is going to be in shambles. I got a message from the other hospital I work at, 2 consultants I work with, 3 registrars, and one of them just today, Jignesh, get well soon. And all these are very, very careful with 2 years of the pandemic experience behind them, were infected or are infected, which means double duties for the others. You also need to factor in long COVID. Long COVID will occur irrespective of the initial severity of your infection. Even a mild infection can lead to long COVID syndrome. And from colleagues who have caught it 1 year ago, 1.5 years ago, and are still suffering physical fatigue, mental fog, just not at their best. It is not something to be scoffed at. And remember that South Africa, that India have a younger population. Why are the UK and the US, for example, being so badly hit? It is the elderly and the non-vaccinated which will be harder hit. And remember, the initial death data, the initial clinical data is coming from the younger population. We don't know what's going to happen as more and more older people are also infected. And of course, this virus, each case has a huge societal impact. Each new diagnosis, regardless of its severity, will disrupt a family's life, will disrupt the workforce at the place you work at, will disrupt your social life, your meetings, and every aspect of your life, really. What about the impact on schools and our kids? It continues unabated. Schools have just reopened and sadly are often being forced to close again. So don't underestimate it. There is no cause for complacency. And this is a nice modeling exercise which shows this is a slow and severe virus in blue, but this is a fast but mild virus, and you can see the deaths will be 10 times more with the green virus globally overall than with the slow and severe form. And of course, deaths from Omicron are being reported all over the world, including in India, South Africa, in the UK, Israel, US, and increasingly from all over. So please do not make the mistake of thinking that it is invariably a mild or benign or mild flu. And the reason it is now so much milder has also become apparent. And that is, again, I think, a remarkable scientific discovery. And it first came from a team from Hong Kong, and I'll share that paper with you, which showed that Omicron tends to prefer hanging around in the upper respiratory tract, in the nose, in the throat, then going downwards into the lung and affecting alveolar cells. It is much less likely, therefore, to cause the dreaded pneumonia we saw with Omicron. In fact, it grows 70 times faster than Delta in your upper airway tissue as opposed to your pulmonary or alveolar tissue. And this was a remarkable, quick lab-based study from out of Hong Kong, which showed that it's a culture-based study, of course, but it was very relevant. It showed that 24 hours after infection, Omicron replicated 70 times higher than Delta. You can see that here, or the original strain in the bronchus. This is what makes it more infectious. In contrast, it replicated 10 times slower in the lung tissue, and that is what made it less severe. So it is a balance or a trade-off between higher infectivity and less severity. And I think I'd know what I would prefer. Look at this very interesting study from the NHS in the UK on Omicron severity, and all the good data, all the good clinical data, all the advances in drugs, or most of them, I would still have to hand it to the UK, have come from them and not from other more developed countries. So the UK Health Security Agency data showed that compared to Delta, and this data came out long ago, when I say long ago, 1 week ago, but 1 week is a long time in COVID research, that people with Omicron are 45% less likely to attend their accident and emergency services, 70% less likely to require admission to hospital, and when they were admitted, had shorter hospital stays, averaging about 3 to 5 days. And you know the intense pressure on the NHS despite this data. And then there is a published just 2 days ago from JAMA study, which I'm going to share with you on the data from South Africa, the original Omicron severity. And these were the baseline characteristics of wave 4. This is the Omicron wave. So I want you to focus on this wave. And here I've just highlighted that they were younger patients, median age 32. And for some reason, females more than men, though this was just a smaller number of patients than in previous waves, 971. These were admitted patients. And this gives some reassurance that the outcomes of patients admitted, again, look at column number 4, because that's Omicron in South Africa, receiving oxygen only 17% as opposed to 74%, requiring ventilation 1.6%. requiring ICU care 18%. Length of stay median shorter, 3 days as opposed to 9, 8, 9. And deaths were also significantly fewer, 2.7 compared to deaths, with other waves. If I can share my data from one of the hospitals I work at, we have had, I would say, about 8 to 10% of patients admitted in this wave only requiring oxygen. That oxygen requirement has never been more than 4 liters. We have lost one patient, but that was because he also had severe additional comorbidities. And all patients who are unwell enough to need oxygen are over 75. Now, let's move on. Kamlesh raised a lot of interesting points, vaccines and Omicron. Vaccines are clearly less effective against Omicron in terms of the protection they offer against infection. We have data from Denmark now, which shows that even 2 doses of an mRNA vaccine have left that population vulnerable to Omicron infections. Vaccines will, however, and this is the crucial point, retain their efficacy against severe infections, against hospitalization, and against death. And the above, I would say, can be generalized to all the available vaccines. I'm tired of people asking me again and again, which vaccine? Be grateful that you have had any vaccine. And this applies generally to all of them. Whether one is 60% and the other is 70% is not really clinically relevant as long as they can all achieve the same thing, good efficacy against severe infection, hospitalization, and death, even at Omicron time. And antibodies and antibody levels are not the sole correlate of immunity. My mother-in-law is admitted in a COVID ICU despite her antibody levels being 30,000. Again, I'm so tired of people discussing their antibody levels with me. Look, your antibody levels are just one of several dishes in the buffet of dishes that is your immunity. It may not even be the main dish at all. It's the simplest to measure, and that's why we are so focused on it. But your T cell system, which is impossibly hard to measure outside a research setting, unfortunately, is way, way more important. And that is the system that is primed, hopefully for years after even 1 dose of a vaccine. So antibody levels are not the sole correlate of immunity, and I've given you a personal example to ram home that point. But data from the UK confirm the extent of Omicron's vaccine escape, and this is what is so worrying. That 2 doses of Pfizer in the UK, and this is such remarkably solid data again coming from out of the NHS, and this is from Professor Ferguson and his team at the Imperial, that 2 doses of Pfizer in their population who had been infected with Pfizer, who had been vaccinated by Pfizer, only 20% effective in preventing symptomatic Omicron. That is the crucial point. And you're going to be horrified by this next figure, that 2 doses in their AstraZeneca vaccinated population was 0%. I'm going to repeat that, was 0% or not effective in preventing symptomatic Omicron. So the vaccine that we have is not going to prevent you from picking up symptomatic Omicron infection. That does not mean it doesn't work again. The expectation is that the cellular immunity that this vaccine clearly provides will prevent what I told you it is meant to prevent: serious infection, hospitalization, need for oxygen, and death. But you can look at the degree of immune escape that this wily virus has manufactured against 2 standard vaccines. And this would again be across all vaccines, I'm sure. But look at this data. When you add on a 3rd vaccine, say a booster of Pfizer, you move from 20% efficacy to 80% efficacy, again in preventing symptomatic Omicron. And when you add on your booster or 3rd dose of Astra, your efficacy goes up to about 55%. And this is a great study just out a week ago in the New England Journal of Medicine on how effective boosters really are against Omicron. Again, it was a lab-based study. It was a very complicated technique called microneutralization assays, which were performed on cells infected by Omicron and other variants in those who had received 2 doses versus those who had received 3 doses of vaccine. And what did they find? They found that receipt of a booster, a 3rd dose, led to better neutralization of all 3 variants than receipt of 2 doses. So boosters clearly help. A booster does increase your protection against Omicron with an increasing neutralization efficacy 100 times more than with 2 doses. So a booster will restore some of your immunity. About 75 protection will occur from symptomatic infection within the first month or 2 only. And then, as occurs with antibody levels with any vaccine in the world, they will wane down. One more reason for not being obsessed with your levels. But even 3 doses, that is a booster, will still be 4 times less effective for Omicron compared to other strains. And that is shown in this slide here, that 3 doses will increase the efficacy, but a booster will still be less effective. And again, real life data from Denmark, which has 80% double vaccination rates. And those who received 2 doses were as vulnerable. Those who received a booster were slightly better protected. And Omicron has made the need for boosters more urgent because a higher quantity of antibodies perhaps might, I said, compensate for them being less well matched. And this is a headline from The Guardian. Israel now offering a 4th COVID shot to anyone 60 or over. Now, this is something which upsets me a little. I think vaccine boosters are a potent symbol of pandemic inequality, of pandemic injustice. Should giving a 15-year-old child in the US be a priority over getting 1 dose into the arm of someone living in Africa? You know that in most huge African countries, for example, Nigeria, the vaccination rates are just 3%. Vaccinating the whole world is not only morally, but also strategically the right thing to do. I think there should be no dichotomy between vaccinating your own country and vaccinating the world, because it is the only way to prevent emergence of mutants. But when will politicians realize that they need to look beyond their narrow borders? And I like this quote from the long-suffering WHO director, who I think has done a great job despite the criticism leveled at the WHO. And he says, no country can hope to boost its way out of this pandemic. And as Israel moves into 4th and 5th doses, and America has 3 doses for standard for everyone, I think this is something that we should pause to reflect on. And this is the other equally worrying weapon that Omicron has up its sleeve, that past infection does not protect you from present Omicron. So many patients, sadly, who were infected in the previous Delta wave just 3 months ago or 4 months ago are now getting ill again, because Omicron largely evades immunity from past infection. And again, that is data from Professor Ferguson's group, who showed that prior infection with other SARS-CoV strains was estimated to give you 80% reduction in reinfection risk. That's what I used to tell my patients. At least you've recovered. You can now take it easy. Not anymore, because protection from a past infection from Omicron will be as low as 19%, as good as nothing. And the risk of reinfection with an Omicron variant will be 5 times greater than it was with reinfection with Delta. So moving on to the last segment, how do you treat Omicron? Symptomatic measures, public health measures, the antibody cocktail should not be used, and we have some antiviral drugs which I'll touch upon. And I would say this is my most important slide. For the lay people listening and the general practitioners who are frontline, the vast majority of your Omicron patients will need no specific treatment, especially if they are young, they are vaccinated, and they have no comorbidities. Symptomatic treatment for fever, for cough, for headache, for nasal stuffiness, and general practitioners are so adept and experienced at doing that, is all that is required. I would urge home treatment for the majority of cases, but bear in mind that there will, of course, be patients who will slip through this net. I do not advise any blood tests for someone who is infected in this strain, at least in the first few days. And please do not do CT scans and radiate your patients when you have the data I shared with you from Hong Kong, showing that pneumonia is much, much less likely here. Having said that, I have an admission at Breach Candy today with a CT score of 20 out of 25. So of course, there will be exceptions to the rule. But I treat my patients, and I hope you do as well, and I'm sure Tushar does as well, and we'll discuss this, along with the reassurance that, look, this is a completely different beast from what Delta was. Omicron and monoclonal antibodies, not to use. Why not to use? Well, if you know that 85% of strains in circulation, and probably more in this country, are Omicron, why would you use a cocktail of this kind intravenously? I would suggest that you have a nice, dry, ice-cold martini instead. It might help against Omicron more effectively than spending a lakh or two on the cocktail. And that is backed by science, because studies in Nature have shown that nearly all the antibody cocktails used to prevent severe disease will fail to stand up to the new variant. So yet another trick that this virus possesses, yet another arrow in its bow. It overpowers the commonly used monoclonal antibody cocktails. And if the head of Regeneron and the head of Roche say, please do not use our cocktail because it does not retain neutralizing activity against Omicron, I think it is irresponsible, if I may say so, to be using it in the present strain. I have stopped. There is, however, one cocktail which is still effective, and that is sotrovimab, and that is made by GSK. And knowing this and realizing this, the whole of US is stockpiling this for future use. And this is quite a remarkable cocktail, because it targets a highly conserved epitope that would not change as the virus mutates, unlike other MABs, which act against the ACE2 receptor, which is a highly mutable region of the virus. So if you do have to choose a cocktail apart from a martini, then sotrovimab is the one that you need to be choosing. And it's not available here, and is unlikely to be manufactured here for now, at least. And this was a wonderful study, the Comet Ice study, in the New England Journal of Medicine from about a month ago, which showed that this particular cocktail was still effective against almost all variants. What about drugs that are effective against Omicron? I just want to make a few general observations on antivirals, because creating an antiviral is notoriously difficult, very tricky. You need to defeat the virus without harming the patient. That's an important point. I said that the drug that you use should defeat the virus and not harm your patient. And that, to my mind, is much more challenging than making a vaccine. As someone nicely said, it's like preventing a fire, i.e. vaccines, versus trying to stop a raging fire, drugs, because you give a drug, of course, after the infection has already started. But there are two important molecules which can have a huge impact on this study, and again, a testament to good science. So let's look at molnupiravir and the very famous Move Out study, as it was named. This comes from the New England Journal of Medicine, and it was published a week ago, although it has been out online for a while. So molnupiravir is a repurposed oral antiviral originally developed to treat influenza and other RNA viruses. It has a very, very unique mechanism of action, something I've not heard of with other drugs. It induces errors in the SARS-CoV-2 virus genetic code. It prevents the virus from further replicating because of these errors which pile up in the viral genome. And therefore, it is a high barrier to development of resistance. But please, please do not prescribe it to all comers. This was the study. Before I tell you why we should not be prescribing it to all comers, this was a move-out study from the NEJM. It was a well-controlled phase 3 double-blind RCT, placebo-controlled, for mild to moderate, lab-confirmed COVID cases, all treated at home, non-hospitalized, but they all had at least one risk factor for severe COVID. That means if they were to develop COVID and their COVID were to worsen, they would have been in trouble, potentially. Now, I just want to go back and say that this was conducted at a time in unvaccinated adults. So this data may not be completely replicable to our vaccinated patients because nearly all the patients you will see are now vaccinated. We won't go into details of the study, but significant numbers, 700 plus in the placebo and the molnupiravir group. And this is the bottom line, that your patient has a 30% reduction, as you can see from these Kaplan-Meier curves, in his death or hospitalization rates if he receives molnupiravir in the first 5 days of his viral illness. And that is, I would say, significant by any standards. But there are concerns. It's a large pill burden of 40 tablets over a 5-day course. It must start early to be effective, within 3 to 5 days. It has this unusual mechanism of action, and the FDA, when it met and deliberated for several meetings, raised red flags over the possibility of some dreadful super mutant strain emerging. And this doesn't seem like a purely theoretical fear if you understand the mechanism of its action. It's teratogenic in females. In hamsters and hamster ovary, it caused fetal defects. But even males who want to conceive, so young couples, if you have them, even males who want to conceive in the next 3 to 4 months should not be given the drug, even if they want to start a family 3 or 4 months later. And in the pediatric population, not in adults, it can cause bone and cartilage toxicity. So these are the concerns I've raised. Would I take it if and when I'm infected myself? I don't think so, to start with at least, when a simple paracetamol might do the same if you are reasonably fit and immunocompetent. But what I really worry about, of course, with the present pandemic is my immunodeficient patients, my elderly patients, my patients with cancers. These are the ones where I would certainly consider, if they have comorbidities, if you've discussed the pros and cons of the tablet, using this drug. And of course, in this country, everything is taken to excess. Globally, countries all over the world are trying to get stocks of molnupiravir and the other drug I'll talk about. Here in India, everything is done to excess. We have 13 manufacturers of this drug, generic versions. Again, you're never sure of the quality of the drug you're getting, but there are 13 manufacturers which have all received fast-track permission. As GPs, you often feel compelled to use it. Resist that compulsion. I would still say that the best doctor is one who has the smallest prescription. Why not just say paracetamol, Allegra if you need it? I don't think your patient will think any less of you. These are my personal views. Again, let's see what Tushar feels about this. And the FDA panel backed this drug, molnupiravir, by a very, very small margin after a lot of debate. And this is one of the dissenters who said, I voted no. The modest benefit of the medication does not outweigh all the potential safety issues. She felt we needed more efficacy and safety data. France cancelled its order for Merck's COVID-19 antiviral drug. When the final results in the NEJM study I told you about were shown to be less promising, 30% reduction only compared to the initial reports where they said as much as 60%. And then there is this other drug, which is probably the superior drug, if I may say so, Paxlovid, not yet out here, made by Pfizer. And if you had shares in Pfizer, what with its vaccine and with this drug, I think you could afford to retire. And this is what their chief scientific officer said: "We were hoping that we had something extraordinary, but it's rare that great drugs come through with almost 90% efficacy, 100% protection for death, and that's what this drug seemed to show. But this, I must stress, is interim analysis data. This is not yet published data. This is data released by the pharmacological company. I'm sure it will find its way into the New England Journal of Medicine or Lancet, but let's look at it because it's very promising. 775 adults, and those taking the drug had a 90% reduction in their combined rate of 30-day hospitalization or death. Only 1% of patients who took a course of this drug, again 5 days, needed to be admitted to hospital versus 7% who took the placebo. No deaths versus 7 deaths. Again, very promising initial data, but again, a drug which has to be used very carefully because it is a huge number of interactions. It is a combination drug. One of the combination drugs in it is a protease inhibitor, one of the HIV drugs, so a strong medicine, and it has to be used responsibly because it interacts with a host of common cardiac drugs, etc. So please use these antiviral drugs responsibly is my urge to all of you out there. And Israel, I will give you an example of what I mean by responsible use of antivirals. And really, in a sense, Israel, because of its close tie-up at the start of the pandemic, just when it started with Pfizer, really are pioneers in the field of vaccine rollout and drug rollout. Look what they did. Digital records are kept on each patient at home who tests positive. It's a small country, so they can do that. They will identify digitally who deserves the drug by virtue of comorbidities. And the drug is dispatched to the patient's residence to start the course of molnupiravir as soon as the patient qualifies, even with a home antigen test positive. Because speed is of the essence if you are going to use this drug, most effective in 3 days and up to 5 days, not beyond that. And then there's been the resurrection of an old drug, remdesivir, after this, again, remarkable study called the Pine Tree study, where only a 3-day outpatient-based course of remdesivir in patients with mild disease reduced the risk of progression. You know, all of you, that the previous remdesivir data was all in the most severe patients, the ones on oxygen, the ones in ICU. These were OPD-treated patients. Just 3 days, not the traditional 10 first and then 5. And the Pine Tree study, that it did reduce the progression almost as much, 90%, as the cocktail did, for example. And it was safe on an outpatient basis. So it's another option that you can consider, 3 days of remdesivir in hospital on an outpatient basis, maybe not even admitting your patients. So I'm going to summarize here. Omicron is the most highly infectious respiratory virus the world has seen. It is fortunately less virulent than the predecessors, but a viral blizzard can be predicted in the next few weeks. There are Indian projections which say that maybe by late February, March, things will be a whole lot better. But wear your seatbelts. We're in for a bumpy ride over the next few weeks for sure. Omicron shows immune escape from 2 doses of all the current vaccines. Vaccines will still, however, retain their efficacy against severe infections, hospitalization, and death, as you're seeing. Boosters will give additional protection against Omicron, but less than they did for other strains. Past infection will not protect against reinfection by Omicron. The MAP cocktail will not help. Antiviral drugs are useful, but not for all comers. Can you please give me some good news? Well, yes, that the outbreak in South Africa is on the decline already, that perhaps the Delta strain, which was far more virulent, is being replaced globally by a milder strain, that a South Africa study shows that people who have recovered from Omicron may be able to fend off later Delta infections. And as millions are infected by Omicron, the world inches closer to that elusive concept of herd immunity. But this is not a foregone conclusion. Because again, the immunity that you get from Omicron may provide only very weak or transient immunity. So what's needed are vaccines against possibly the variants of concerns as well. And all the big companies from Pfizer to Astra have already started clinical trials looking at vaccines which will help against variants. Whether they are needed or not, I cannot be sure. Maybe a pan-corona vaccine is the ultimate holy grail. They're looking at boosters, of course, and their roles. And I get really upset when the Indian government calls it a precaution dose. I mean, what do you mean by precaution dose? This dose, according to me, should have been given out a while ago. It would have perhaps, when we had adequate slot, equipped us perhaps to deal with this outbreak better. Just today, I finally received this morning, like all of you must have, by WhatsApp, a note saying that I could finally take my third dose, my precaution dose of the vaccine, because I had crossed 9 months or whatever the period was. So I think it's a euphemism to call it a precaution dose. Call it a booster, call it a third dose. Antiviral drugs we've discussed. Masking remains crucial. Don't let your guard down. I would say that N95 is what you need in these days, even for the public, of course, provided stocks of the masks are always there. A normal surgical mask is not good enough. And Time magazine had this headline, make 2022 the year of COVID testing. Use the rapid antigen test more frequently, more responsibly. Update your data to GISAID so we have regular surveillance for variants. We picked this one up early, fortuitously, because of South Africa and Botswana. And I think what we really need is a global body, like the WHO, because we have no one else, which is entrusted to fair, rapid vaccine rollouts. And I hope that governments from all over the world will realize, as I told you, that this is the need of the hour. And how Omicron plays out will therefore depend on the balance between its increased infectivity versus its reduced severity. We cannot know before you ask if this is the last variant of concern or another lurks ahead. There will be others. Every infected person anywhere in the world gives this virus a chance to mutate. Less people infected anywhere means less mutants emerging anywhere, and therefore less mutants eventually entering your country. How we emerge will depend on the extent of our vaccination and our adherence to social distancing. And I'll end with this wonderful quote from The Atlantic, which has become my new favorite general public periodical. It's really an amazing journal. No combination of primary vaccines, booster shots, and variants will sadly add up to being done with COVID forever. Everyone's personal COVID calculus is part of a global whole, Catherine Wu says, and she's a remarkable science journalist. Thank you very much. I will stop sharing. Sorry, I've been a bit longer than I should have, Tushar. My apologies.
I wish you could go on. Thank you so much, Dr. Zarir. Dr. Jawahar, I think you should take the mic.
Jawahar, you are muted.
Thank you, Dr. Dwadia. As always, it has been a fantastic time just listening to you. You mentioned that the best the virus could aspire to was to be classified as a variant of concern. All I can say is that the best this August audience today, Sunday morning, could aspire to was listen to you. And I think you fulfilled our aspirations.
Thank you.
Thank you so much. Thank you. I would now, without any ado, ask Dr. Tushar Shah to proceed with the question answers.
So we are doing some questions and answers, some of them from our panelists, eminent panelists. Dr. Zarir, we'll start with Dr. Asha Vasani's question. She's asking, what was your experience with remdesivir in Delta and what is it in Omicron?
Well, in Delta, it was the only available antiviral drug, the only intravenous antiviral drug. It remains a very effective drug. It should be used early like any antibacterial or antiviral. And yes, used within the first 3 or 5 days, it was all we had. In Omicron, we have many patients just now who are more badly hit, who come in earlier, where we use it too. And Tushar, I'd like to ask your experience on it as well, because you see more cases probably than I do as well. What has been your experience?
So, I trust remdesivir, definitely. I have trusted it all through the last year, first wave, second wave, and third wave. But despite all the controversies and despite the fact that USA had approved it only for hypoxic patients, which was a little illogical to my mind, but still we used it, and I think we are okay. Currently, I have just given it in 3 or 4 patients in the revised dosage form in early Omicron infection. I was wondering if, with the doubts about molnupiravir, and especially the fact that molnupiravir trial was done during Delta, whereas the remdesivir trial probably includes Omicron, should we prefer remdesivir over Omicron? Over molnupiravir?
I think the great advantage is it's oral and therefore can be prescribed at home by the majority of you practitioners. But as I said, my only request, and I'd like to hear Tushar's thoughts on it as well, when the average patient phones you up, is not to give it to everyone. Discuss the pros and cons, tell them why they're a candidate for this new antiviral drug, and tell them there's an equally good chance that they might get well just with symptomatic treatment. Would you agree with that?
My only worry was that it was tried in Delta in unvaccinated 2 areas, and 30% reduction, whatever was seen, the absolute reduction was 5%. But if we count even a 30% reduction, that reduction in Omicron, even if it holds, then Omicron itself is causing very few hospitalizations.
Absolutely.
That's my worry. But yeah, I think something. Dr. Kumar is asking about your opinion on monoclonal antibodies being given rampantly currently in all over the city, at least in Mumbai. Do you think it will cause any side effects?
No, it's safe. I mean, you get the occasional patient who gets an allergic type reaction, which settles usually with a shot of IV hydrocortisone. But I mean, science has to keep up with new knowledge. So it worked with one strain; it's known not to work with the other. So why would you use it now that you know that it doesn't work? There's no reason to be using it, or hardly any reason. Yes, unless a patient comes to you with a report which shows, look, I don't have S gene dropout. This is very likely to be Delta. He's very unwell. Such a patient, and they're going to be rare, in the first 5 days, you could consider it.
Correct. Dr. Bhairavi asks, what is the role of blood tests, especially CRP, in Omicron, in outpatient?
I told you, Bhairavi, not as a routine. Again, you're in a difficult position. General practitioners, your patients almost expect you to be doing blood tests, expect you to be giving them some drugs. But why not take a stance and say nothing is needed for now? If your fever doesn't settle in 3 days, in the UK, they would not do a single test on a patient as he gets hypoxic till about 7 or 8 or 10 days. They're so, I wouldn't say laid back, but they're so system driven there. So no unnecessary tests. And yes, CRP levels and D-dimers are less. We will all agree in this wave, often normal. So then why do the test?
Agreed. About the burning question in the minds of every family physician is, how do I symptomatically treat the throat symptoms? The throat symptoms are very, very severe. Cough is bad, throat pain is bad, and whatever symptomatic we give, at least what I give, it does not seem to be working. What are your thoughts?
I think most general practitioners are better equipped to handle general throat symptoms than you and me, Tushar, because they do it over the years, all their lives. So I would just go for the usual cocktail of steam and lozenges and gargles. And I find for the racking cough, which can occur because of bronchial hyperreactivity, a steroid-based inhaler has been shown to be useful. Something like budesonide inhaled, not nebulized, because you don't want to disseminate the virus. And it settles. The patient just needs reassurance that the cough will take weeks. Just say that up front. The cough may be the last symptom to go after several weeks. Throat pain, rarely a need to take an antibiotic. I mean, unless the fever is very prolonged. No need, I would say. So that ASI should also not be a part of your routine prescription. I know family practitioners love that drug.
And Ziffy. Okay. About indoor patients, what is your current indoor patient experience in terms of why are the hospitals full? I'm not getting a bed in Beach Candy, not in Hinduja, not in Leela.
One at any of the 3 hospitals I work at and all the ones you work at as well, Tushar. And that's because many of the patients who are there don't need to be there. So-called VIP syndrome, so-and-so BMC corporator's mother or father or wife, just wants to come in as a security, comes in to demand the cocktail, which at least I refuse to give in to the demand. So many of them don't need to be there. But again, we talked about the extreme infectivity affecting more and more, and even a small fraction then resulting in a large total. So we have patients just now who are on oxygen, who are in the ICU, but less ill and less numbers clearly than there were. But the sheer numbers may overwhelm in this wave.
What is your opinion on outpatient steroid use, considering that there is bronchial hyperreactivity?
Not really.
Oral steroid.
Not really, very seldom required. I mean, again, the general rule, second week you can consider it if there is something like an immune reactivation, or there are severe symptoms like a fever not breaking when nothing else has come up, but not in the first few days, not in the first 5 days at least, for sure. Don't use them.
I have believed that the usual comorbidities that we used to call in Delta as high-risk situations are less of comorbidities in Omicron. Would you agree, disagree, and what should we look out for?
It's just now the younger patients are often being hit because they were less vaccinated or vaccinated later. And that might be an issue, but I think you will eventually see it spread across populations. And I think the comorbidities we worry about will remain, Tushar. The extremely overweight person, the person over 75, the person who's diabetic, hypertensive, ischemic heart disease. Those I think stand till we get more data.
So maybe can we say that the family physician may refer early Omicron with comorbidities for remdesivir therapy?
Remdesivir or molnupiravir,
if you like.
Discussing the pros and cons of both, absolutely.
They should be referring more.
I think so.
And
as you said, even molnupiravir, knowing that a drug is 30%, 1/3 of you, 1 out of 3 people who receive the drug is less likely to end up in hospital. That's a chance many people would be more than happy to take.
And what about the days? Meaning, you said within 3 or 4 days, usually the patient gets better. Should we wait for 4th day? Meaning, should we wait it out or give it on the first day, second day?
Sit it out for a couple of days. For so many patients, within 2 days say, look, doc, I'm already better. My fever, which is 102, is now 99.5. And a good general practitioner will sense that this patient is getting better when I speak to him, or clearly getting worse. And then you're still at day 3. And again, the rapid antigen test is useful here because it tells you those who are most infective, those who are clearly positive. And otherwise, a PCR report can sometimes take 2 or 3 days again to come in some parts of the city again.
True.
You've wasted that initial window of opportunity.
When would a family physician hospitalize a patient? Other than hypoxia, before hypoxia is an obvious.
Yes. I think generally a person who looks very sick, whose fever is not settled by day 5, whose saturation is starting to decline, and who's just not getting better, maybe despite a couple of days or 3 days of the molnupiravir as well, I would say come time to start intravenous remdesivir and have better monitoring that only a hospital could provide.
Do you think remdesivir at home is safe?
Well, in this study, which I quoted, the Pine Tree study, it was safe on an outpatient basis. I think our general practitioners are quite a hardy and brave bunch, many of them. And I can see some of them wading into battle and giving remdesivir at home. So who knows? I think I leave it to your judgment. But in this study, there were no major side effects when taken in an outpatient basis. So perhaps why not? If there are no beds, for example, as happened in Delta.
Yeah. What do you think about isolation periods?
Shorter and shorter for this virus. It comes fast and goes fast. And I told you, the CDC says 5 days, some centers even less. So not very prolonged isolations. And for doctors, we don't have choice because, we're all doing double rotas these days. So the quicker a doctor, within a couple of days of being asymptomatic, can put on an N95 and get back to his COVID duties, the happier I would be.
What about isolation? Not asking for isolation at all in doctors if asymptomatic.
No, I think it's your duty, at least if you test positive and you have a rapid antigen test positive, to be in isolation from the family and from your patient's point of view. A patient wouldn't perhaps like to go to such a doctor if he knew his rapid antigen status.
Many patients do their own rapid antigen after 7 days of isolation and tell us that there is a faint line still. Should we come out?
Yeah, none of these tests are used to tell you really logically how long you need to stay isolated.
You should not depend on the rapid antigen test, maybe on symptoms.
Not completely on that, though a rapid antigen test will turn negative far faster than a PCR, which can stay positive for 100 days. And that should never be asked again from a patient, because again, it will just cause confusion and a bit of panic.
Right. About vaccinations. Before that, about long COVID. Do you think long COVID will be less in Omicron than in Delta?
Hard to say.
Hard to say.
It's too short just now for us to know. So long COVID will be measured over time. And I fear a surge of patients with long COVID if it behaves like the previous virus. And there's no reason to think it won't.
Okay. What is your experience with long COVID of Delta? Because those will be coming to us now, even now.
It's a very it's a very hard question. We have no data. No study so far has solidly told you that this drug is worth trying. So it's a non-evidence driven field. And I guess psychologically also you need to cajole the patient and keep their spirits up. I do believe it is very real. I don't think it's something, so many doctors dismiss it and say, oh, nothing wrong with you. If you are unfortunate enough to be afflicted badly, colleagues who are strong, young colleagues who've had it tell me that their lives are ruined for up to a year before they can slowly resume anything like their normal levels. So we must treat them with sympathy. And you really need a holistic approach to treating these patients symptomatically. Hoping that a new drug, and there are trials underway, will show us that, that there is something new on the horizon.
What is your take on the fibrosis that has happened after Delta in many patients? Is there a long-standing fibrosis?
It is. I have to say, first, I raised red flags in the initial days of the pandemic, but I must say it's very rare. Almost all the patients who were requiring oxygen, even 6 months after a bad Delta, are off it 1 year later. They will be left with residual scars. They'll never have a normal CT scan. But lung function, except for diffusion capacity, reaches near normal. They will never be left, some of them, the most severe ones, with completely normal lungs, though.
Can we ask the family physicians to start tapering pirfenidone or the other drugs?
They shouldn't be used. There's no study which shows that any antifibrotic has a role, to be honest, in the fibrosis of Delta. And often just time is all that you need.
So a message to the audience might be that you start tapering or reducing or stopping the two drugs that have been used.
Stable on follow-up and the scans are getting better, just stop the antifibrotic if they were on them.
About vaccinations, what is your view on boosters in those who have double vaccinated and have had Omicron currently?
That's a difficult question to answer. I think those who had Omicron don't need to be in any hurry to get vaccinated. The later they take it, the more time they will have for antibodies to develop. They have their own. They can't get Omicron twice, as far as we know. So tell them to wait for 3 months. And as for the rest of us, I think all of us must be in the same boat. Did you get a message today saying you're not maybe over 60, Tushar, but I got a message over 60, 9 months, and you can take your booster finally. So many of you must have got that just today. It's the first day, I think.
It's the first day. What is your opinion on boosters in those who had COVID in the first and second wave?
Yeah, I think they should take it. And
they should take it.
I just wish our government we had some research telling us which of our 2 available vaccines would have been the right booster. Surely, again, it was incumbent on the ICMR to have started such research, knowing that there are only 2 vaccines. Let us try and see which one is more effective as a boosting agent in groups who have received one or the other. Such research is underway by colleagues at Vellore just now, right now, but the data is not available in time to inform our booster choice. So we don't have a booster choice. And right now I will take the same booster of the original vaccine, which is Covishield.
Do you think that might be because 85% plus were given Covishield?
Yeah,
and
but still have
those many boosters may not be available in Covaxin?
I don't think so. We'd still have enough in terms of numbers to at least conduct 1,000 plus patient trial in each limb.
True. Very true. Yeah, I think I'm out of my questions. If the panelists have any questions, but I would definitely, Dr. Zarir, ask you to give some comments before you go back to your martini.
No, back to my rounds. I've not taken them. The martini will be at night, hopefully. So I just want to make a few concluding remarks, if I may, Tushar, with your permission. To the most common question I'm asked, how will this end? And that was Anil's question as well when he gave me the topic, beginning of the end, end of the beginning. Those are Churchillian words that he used. So in the end, of course, the pandemic will end because all pandemics will burn out, either when there are not sufficient people to run through because they've been vaccinated or because they've been infected, and most of the globe develops immunity. And then the virus just cannot find any new hosts at the rate which it needs to sustain growth. And therefore, it will end eventually with a whimper, not with a bang, going on with a long, long tail. Yet, having said that, we've only eradicated one viral disease in the world so far, and that's smallpox. Maybe polio will follow soon afterwards. And the majority of diseases, whether it's the common cold, whether it's cholera, whether it's measles, whether it's influenza, become endemic over time. By that, I mean they become part of the landscape of our medical diseases. They are checked, but they are not eliminated. And I feel that this virus will eventually go that way over time. Let's look at influenza, for example. It's a classic example. It's a closely related virus. Influenza still kills 500,000 people every year. But we don't make a big fuss about it. Those deaths are predominantly in the elderly, predominantly in the unvaccinated. Why do those deaths occur at all? Because we don't have a vaccine rolled out across the globe, because the available vaccines are not 100% protective. In fact, the influenza vaccine is just 60% protective at best. And because the virus mutates faster than we can keep up with any vaccine. So I have a feeling that corona will go the way of influenza over time. Over 4 or 5 years is my estimate. If we are really, really lucky, it might go the way of other coronaviruses. As you all know, there are 7 coronaviruses, of which 4 are just common cold viruses, closely related in terms of their genomes to the present SARS-CoV-2. And these viruses would not even reach a general practitioner. A few days of sniffles and coughs and colds. If we are really lucky, that could be what SARS-CoV-2 eventually gets to again in 4 or 5 years. So somewhere like either influenza at one end, or like the simple common cold corona flu virus at one end. I really don't know. I don't know for sure. If there's one thing this virus has taught me is how little I know myself, and that you constantly need to update yourself like all of us are updating ourselves. So thank you very much, Tushar. Can't hear you.
Thank you so much, Dr. Anil, Dr. Jawahar. Any remarks?
Thank you. Thank you for spending time with us on this Sunday morning.
Thank you.
And I know you're busy and you need to go. Thank you so much.
Thank you. Thanks for asking. Bye.
I will now, we have a special guest today who agreed at the last minute to join us today, and that is Dr. Avinash Phadke. I would like to welcome him. Has he joined? Please show yourself. Yeah. I would like to welcome Dr. Avinash Phadke, who is founder of the Dr. Phadke Lab, president and SRL Diagnostics. He's revolutionized the pathology industry in India as one of the renowned Mumbai. Besides running a chain of his own labs, he also heads various institutions in the medical sector as a director of India Venture Healthcare Fund, advisor and mentor, the Association of Practicing Pathologists of India, trustee and member of the governing board of CanCare Trust Cancer Hospital, a member of the steering committee of the Aga Khan International. He's also a guest faculty at the Tata Institute of Social Sciences, Bhabha Atomic Research Center, and the Mumbai University. He's participated in more than 400 regional, national, and international conferences. And I was looking at his bio, and I found a quote that he said that he is supposed to like from Lawrence Miller, PhD in Florida, which I was researching. And he's a clinical and forensic psychologist, and he says, quote, "By the deficits we may know the talents. By the exceptions, we may know the rules. By studying pathology, we may construct a model of health." So Dr. Phadke truly believes in the potential of pathology in human health and well-being, and he has earned many laurels and awards over the years, far too many to be recounted here. Professional of the Year, Distinguished Doctor Award, top 3 pathologists in Mumbai, named as the best 50 healthcare professionals, lifetime achievement awards, etc. Without going into much ado, I would now like Dr. Tushar Shah to start the proceedings and discussions with Dr. Phadke.
Dr. Phadke, first of all, congratulations and a note of gratitude from all us family physicians for providing Mumbai with one of the best lab infrastructures that you have given. Sir, first and most burning question is there a Omicron specific RT-PCR coming up soon?
Okay, so I will answer it in two ways. Currently, you are guessing Omicron by two RT-PCR this thing. One, your H gene is weak, so your CT value of H gene is higher than E gene or N gene, is one way to suspect but not detect. The other is a missing H gene, and you must have read that H gene knockout is a classical feature of this. But the second question I wanted to ask the clinician, and we have discussed it in the task force, is your clinical management going to be different whether it's Omicron or not? I will give you the example. In Bombay, you get retrospective data from BMC of genome sequencing. In Bombay, about 84% are Omicron currently. In Pune, this number is 50%. So does your management of COVID differ in Bombay and Pune? The answer is no. To answer to your question, is a specific kit coming for that? There is a Tata kit, and I'm very proud to say we have tried that. We are the first lab in the country. There is a Tata machine which has come, which is called OmniSure kit, which is capable of detecting on conventional RT-PCR Omicron variant quite specifically close to 95% correlation with genome sequencing, and it would be available soon. But the other answer to it is, today we have Omicron, earlier we had Alpha, before that we had Delta variant, and new ones would come. So how often, just like Dr. Udvadia said, how often our technology will keep up with identifying new strains, and would it make a difference in clinical management? So that's the answer to your specific question.
So basically, we are keen because clinical management will differ. If it is Delta or Omicron, we know that the current available antibody cocktail of casirivimab and imdevimab does not work in Omicron, but does work in Delta, and actually can be life-saving in Delta and not in Omicron. So if even 15% in Mumbai or 50% in Pune are Delta, it would be good for us to know. And second reason is, if we once, because Omicron is gradually increasing, if we once show that Omicron is the predominant strain, then the misuse of the cocktail in Omicron, which it is not effective, misuse will end. There is one thing about good use and one thing about stopping misuse. So I think there are these two advantages for which we are looking forward. But I think you're right. In the days to come, maybe Omicron will become 100%, and we may not need the kit at all. That is true.
Yeah.
So,
Please,
yes,
please. No, I just wanted to share with you, yes, there is some protocols which say that currently, as on today in the city, Omicron diagnosis is a retrospective diagnosis and not useful in clinical management. Our decision to give cocktail is based in first 48 hours to 72 hours. And within that time frame, that information currently is not available.
Correct. Second question is, in your lab, of course, you do the rapid antigen test also, besides doing the RT-PCR. Is there any study in your lab which compares the sensitivity of the two?
Yeah, I would say rapid antigen, if it is positive, it is almost 95% correlation with conventional RT-PCR. If it is negative, your chance of missing out actual positive cases is almost 40%. So I would say a positive antigen test is good enough, as nearly as good as RT-PCR, but a negative one, if you have a close family contact and you want to say that you can mingle around because you are negative on the basis of antigen test, that assumption is not valid.
And the sensitivity of RT-PCR is how much? 70, 80% or more?
See, we will say that the specificity of RT-PCR is 98 to 99%, but the sensitivity, you are absolutely right, is only 70 to 80%.
Okay. we have reduced our blood investigation of CRP, D-dimer in Omicron. What is your input from your lab? Is the testing as frequent currently as it was during Delta, or has it gone down?
No, I think it is definitely down compared to Delta. You are absolutely right. I think we should classify cases as mild, moderate, and severe, so everybody understands what we are talking about. In mild illnesses, you can do only CBC, creatinine, random sugar, and C-reactive protein. In moderate, you can add D-dimer. It is only in severe cases you should be looking for inflammatory markers like IL-6 and ferritin, and not in mild to moderate cases.
Is there any way that labs can discourage family physicians from asking from IL-6 and ferritin on an outpatient?
Yeah, it's a difficult question. I have been, whenever I am giving symposium or even in the task force, which is now IMA has convinced a new task force, which I am part of. So we have decided not to ask for too many investigations because it just defeats. First of all, they are not widely available. Secondly, you will see that IL-6 is the most misreported test, because if it is collected in a plain tube, an assay is done after a few hours, a false elevation is tenfold. So what report of IL-6 you get is meaningless. So I have been trying to tell everyone that IL-6 should be done only in cases where there is severe inflammatory response. It should be done only with EDTA vacutainer, and the sample should be analyzed in 2 hours to get a reliable report.
Can the lab tell their patients that we will not do IL-6 if you are not hospitalized? I'm just asking, is there a possibility?
I think those days of discretion of patient advice lying with pathologists are still far away in India, and I don't think they would come. I think patient trusts and believes his family physician more than anyone else. And I think it's up to family physician to educate the patient. Pathologist can suggest to family physicians, but he shouldn't directly propose to anything to the patient.
So true. Thank you so much, Dr. Phadke. Very, very valuable input for all of us. Thank you, sir.
Thank you.
Over to you, Dr. Jawahar.
Thank you, Dr. Phadke, for throwing good light on the subject. We will now proceed to our next session, which is a question and answer by Dr. Tushar Shah with all the panelists and viewers. I would like to call upon the panelists, our esteemed panelists, Dr. Nisha Kushlani, Dr. Manoj Malkan, Dr. Janak Shah, Dr. Sunita Manglik, Dr. Kumar, Dr. Kambati, Dr. Meeta Gala, Dr. Bhairavi Shukla, and Dr. Rushin Mehta. Of course, Anil, Dr. Anil, Dr. Kamlesh, and myself will also be part of this panel. Thank you. We can go ahead with the question answers. I would first ask, hello? I think we need to unmute. Everybody needs to unmute. Please unmute all of them. So I would now ask Dr. Tushar Shah to go ahead with the first question coming from Bhairavi.
Sir, I think all the questions I had were answered by the question answer session that you conducted. Thank you so much. And thanks to Dr. Zarir also. And thanks to you.
There is a question from Dr. Manoj Malkan. Can a person take Pfizer vaccine as a booster if the primary vaccination was Covaxin? I think he's asking. So no data after Covaxin 2 doses. What is the correct booster? We don't have, but my opinion has been that we should change the formulation as the third dose. And my recommendation previously in India also was that if 2 Covishields have been taken, 1 Covaxin should be taken. But the government is not allowing that. So right now, I don't think, if you are traveling to the US and if you're older than 40, then you can take Pfizer or Moderna, because below 40, I don't think Pfizer Moderna should be taken because the risk is more than the benefit. As you know, Moderna and Pfizer are responsible in the young for myocarditis, and the incidence of myocarditis, which started as 1 in 50,000, then became 1 in 20,000, now is considered 1 in 2,500 in the young people. So I would strongly say that if your child is going to college to the US, unless they make it mandatory, do not take the booster as Pfizer or Moderna. Dr. Malkan also asks, which inhaled steroid is superior? My opinion on this is like this. I'm still formulating a strategy for inhaled steroid in Omicron. I was against inhaled steroid in Delta because the infection was alveolitis, the inflammation was alveolitis, where the reach would be less. Now we know that tracheobronchitis is a problem with Omicron. So I'm still trying to figure out which is better, a bronchodilator but which I don't know whether they work or not. You know, all of us are giving currently empiric therapy in the throat symptoms and cough. But I think, logically speaking, if tracheobronchial hyperreactivity is a problem, then both a steroid and a short-acting beta agonist should help. Something like levosalbutamol with budesonide. Instead of salmeterol, you would rather use levosalbutamol. But this is something that is an idea in evolution. And so then the last question by Dr. Manoj was, should we start molnupiravir only on RAT positive? Of course, for any antiviral drug, you need proof, either in the form of RAT or Rtpcr or even CT scan in remdesivir. As my opinion on molnupiravir is different from Sir's opinion on molnupiravir, simply because, again, I will reiterate, trial was in the unvaccinated, trial was in Delta, and in Delta, if the protection was 30% in patients with comorbidities, then in Omicron, hospitalization where anyway is much lesser, I would not like to give a toxic molecule like molnupiravir. So that is my opinion, but that is, of course, debatable because most pulmonologists currently are giving molnupiravir. I'm in the minority in this.
Yeah, Jawahar.
Yeah, Dr. Asha Vasani. Dr. Vasani.
Yeah, hello.
Yeah, you can go ahead.
Somehow it's not working, I think.
I can hear you, Dr. Vasani.
You are audible. Please go ahead.
Okay, Dr. Kumar, you have raised your hand.
Hello.
Yeah, hello.
Yeah, can you?
Dr. Meeta Gala, you can go ahead. Unmute.
Meeta, unmute.
Hello, can you hear it?
Yes.
Yeah, so my basic question is, lots of general practitioners are attending physically their clinics. So what I should put on? My N95 mask with a cloth mask, plus shield, plus PPE kit, and how should I sanitize? Because everyone is having symptoms and everyone is, whatever is coming, they are COVID positive. So what should be my approach? And above 60 years of age, whether those family physicians should avoid, or what is your view on it?
My view, which is a little odd, is that you should get infected. And you should get infected with a low viral load. The key is the viral load. There is no escaping Omicron if you are not going to be imprisoned in your room or in your house. You are not escaping Omicron even if you go to a jogger's park. Maybe you'll get it there also. But the point is, you have to get a low viral load. The whole point of masking. So if you are in your clinic with an N95 mask and a surgical mask over that, or a cloth mask, a double mask in effect, there is no need for face shield. There is no need for PPE kits. In fact, we should stop using those because we are actually causing a great climate damage by using these. Don't use gloves. Just sanitize your hands or wash with soap and water. And see patients at close contact. If you are, I don't see, frankly, I am a hypocrite in that sense, but I manage only telephonically because I can manage much better telephonically in terms of numbers. And we are working currently 18 hours a day. But in the clinic, if you're managing, go all out, touch the patient, examine the patient, get the infection. If you've not gotten it already, you will be having two advantages. One, you will become free to move, to travel. Second, you will probably not need should not take the booster at all. Once that happens, low viral load, even to the general public, I would say the time will come when we will say, okay, get out with a mask, even if it is in a dense population, like a movie theater. Get out with a mask and get the infection. It's a slightly, and in the elderly, it might be different because we have started seeing hospitalizations in the very senior. I'm talking about very senior, 75 plus, especially. The elderly you should protect more than the younger than 65. I would say 65 or 75 maybe is the cutoff.
Okay, thank you, sir.
I think there was a question about vaccinations in lactation and pregnancy, which you might.
Pregnancy, we all know that in Delta, they were strongly advising vaccination because Delta caused premature labor, preterm deliveries, etc. We don't have data about Omicron affecting the pregnancy, but my gut feeling is that Omicron will not affect pregnancy adversely. Just as influenza does not adversely affect pregnancy in any significant manner. So Omicron will behave like that. I'm not pushing vaccinations in the young. Also, if they want to take vaccination or if there is mandate for vaccination in everybody above the age of whatever, then they should take Covaxin, because I do believe that Covaxin does not have the side effect of VITT, that is the thrombosis, as Covishield has. So if in a patient who anyway has a very low risk to Omicron, like a younger patient, then, and if they are taking the vaccination for the first time, let it be Covaxin, because now Covaxin has been approved by most countries for travel.
Okay.
Dr. Sunita?
Yes, sir. So, Tushar, sir, if there are no symptoms in the family members of the patient who's positive, then in how many days should we test the family members for COVID?
So as Dr. Zarir said correctly, that 3 days is the average incubation period. You can either test, I would do testing twice. One is immediately and one is after 3 days of last contact with the isolated patient. And the reason for testing all family members is twofold. Again, one, you can advise isolation and not, so for example, a person who's a school teacher will not go to the school. Second, you will advise against boosters or third doses. So there are two advantages of diagnosing. For example, if I were to take a booster in this pandemic where I've been out a lot, I would do my antibody test to the nucleocapsid antigen before I take the booster. I would do that because I don't want an unnecessary third dose. Even if I have never been symptomatic or never have tested for rapid antigen. I don't know whether I answered your question. I might have
sir, you did.
diverted. Yeah.
No, sir. Thank you.
There's a question which has been repeatedly coming in. People want to know whether this is going to be an annual booster that people will need to take. Dr. Vishnu Mulchandani has asked this question.
Dr. Vishnu, great question. I would say that, as Dr. Zarir again said, whether this turns into a common cold coronavirus or it stays as a more morbid virus, we don't know yet. If it becomes a common cold virus, then we won't need annual vaccine. If it becomes an influenza-like virus in its symptomatology, we will have an optional vaccine for those with comorbidities. But if it becomes a delta and stays like an annual endemic delta, then of course we'll need new vaccines every year. It is going to be very, very uncertain going forward.
I think there are lots of questions on the YouTube about mix and match vaccines.
So again, as I said, mix and match is not an option here in India yet. And I do believe that mix and match, even if we don't have any studies related to Covishield plus Covaxin, I think we should mix and match. Take the third dose as Covaxin if you've taken Covishield, if it is available, but it's not available, so there's no question. But those who travel abroad and get a chance to take Pfizer, Moderna, or if you have taken Covaxin here and UK, you get Covishield, then mix and match. And if, of course, if you mix and match, you won't get any travel mandate or a certificate, a vaccine certificate, if you mix and match relevant to India.
Dr. Kumar, Dr. Janaksha, questions?
Yeah. Can you hear me?
Yeah.
Yeah. Dr. Tushar. Hello.
Yeah, go on, Kumar.
Yeah. You have been seeing some patients with hypoxia in the current wave. Are you finding any difference compared to Delta, and also as far as CT scan is concerned?
Yeah, that's a great question. We have been saying, all of us have been saying that Omicron is milder, and there has been criticism on that front. Don't call it milder, just call it less severe. I don't know what that means. But what we have seen in the last few days, and of course, Kumar has been on our team, Dr. Berge has been on our team, we have seen that there are some patients who come with hypoxia. Occasionally, we see hypoxia early, like 4th day or so. And we are wondering, actually, we are just trying to still ideate, but we are wondering whether there is hypoxia due to bronchial reasons rather than due to parenchymal reasons, meaning COVID pneumonia is not the cause of hypoxia, but bronchial hyperreactivity and transient obstructive lung disease is the cause. I am hoping that that is the cause, because bronchial hypoxia can be treated at home, just like you treat asthma or COPD transient hypoxias at home. I do believe that we will, in a few days only probably, we will come to know what is the hypoxia due to. Also, please tell your patients to buy a new pulse oximeter or change the batteries of the pulse oximeter, because all our pulse oximeters have been lying in our cupboards with their batteries inside, and we just took them out. So get them kind of renewed, and keep 2 pulse oximeters so that you don't panic. Dr. Kumar always teaches us that rub your hands in an AC environment so that your hands are warm, well circulated before you test your oxygen. So yeah, I don't panic with low oxygen. I think the new value that I would consider in Omicron as a bothersome value is not below 94, but below 90. I'm coming to that, I think, but it's something that I will know more about very soon. Kumar, thanks. Sorry, Kumar, you asked about CT scan. Are we seeing abnormal CT scan? We are seeing abnormal CT scans. We are seeing CT scans of scores of 13, 14, 15 also. But more commonly, even on the 6th or 7th day of illness, we just had a mother of a doctor on the 7th day, I think, or 8th day of illness, who came with a CT score of 3/25 despite daily fever. So what I'm trying to say is that Omicron definitely will cause less lung disease. And how aggressively to manage that lung disease will be a question. An abnormal CT scan is not an indication of steroid therapy. Hypoxia is an indication of steroid therapy. That is what family physicians must learn. Hypoxia is the indication. But in the current scenario, the problem will be this, that because of tracheobronchial affection, hypoxia may be seen without COVID pneumonia or significant COVID pneumonia CT severity score. That is what we need to figure out, whether we treat hypoxia with simple nebulization inhalers and therefore avoid hospitalization is what we have to learn in Omicron.
I think there's one. Sorry, go ahead.
No, thank you, sir.
There is a couple of queries on CT values in tests. How important would you put the CT values at, whether they should be printed or not?
I think there should be a ban on printing. Dr. Avinash Phadke, I would like to know your opinion on CT values, but I forgot to ask you that.
Yeah, no, I agree with you. See, CT value is creating more problems than help. The thing is, if I test the same patient, 2 different nostrils will give you 2 different CT values. That is number one. Secondly, in the same patient, morning and evening, the CT value can change, And thirdly, the information is limited to amount of viral load at that specific time. How your body reacts to that virus is not available to us, and which is the most important thing. So most of the countries are not giving CT values, but here people are getting alarmed if there is a CT value of 12 and getting relaxed if the CT value of 30 or 32 comes. But I agree with you fully that the CT value is not of any prognostic significance.
So would I be right in saying that it's one of the most humbug parameters ever invented?
No, sir.
Yeah, I mean, it helps you only in knowing the viral load. So initially, ICMR had told us not to print it. It is the clinician's demand which has forced laboratories to print the CT value.
Okay.
But laboratories are very malleable to physicians' demands.
In the same line, can I ask one question, Dr. Jawar?
Yeah.
When we are doing the rapid antigen test, it was mentioned that the throat will have much more, the viruses. So, but we are doing it with the nasal. Can it be done in the throat and then send a sample, or it should be done only with the present kits are available? It is with the nose. There are separate kits for the throat, or we should do both.
Dr. Phadke, your question. This is your question. Can we do the rapid antigen in the throat?
Yeah, so you can do rapid antigen in the throat also. I mean, there is no significant difference between doing in nasopharynx and throat. At least we have not found that. So guidelines give you two options, and especially if it's a person who finds very discomforting to have a small swab put in a deep end of the nostril, he would be comfortable with the mouth. Same is true of children who are exposed. In the family member is positive, it's very difficult to take it from both nostrils and mouth in a child.
True. Thank you, sir. Thank you so much.
Yeah. There are lots of questions on Omicron and comorbidities. One is on diabetes. So the effect of diabetes.
Correct. So what I have seen is, because we are seeing 20,000 cases per day in Mumbai documented, and therefore probably multiple times that which are RAT positive but not documented, and multiple times that which are asymptomatic and not documented. So the estimates can vary from 1 lakh to 3 lakhs, I think, per day currently in Mumbai. What I would say is that the number of people with comorbidities is huge. Diabetes is an epidemic in Mumbai. I think that diabetes is not affecting Omicron as it was affecting Delta in terms of making it high risk. So I still feel that immunosuppressed states are more a comorbidity. You should be more careful by monitoring the patient who are diabetics. My suggestion is monitoring means for 3 days, you sit tight. You tell them, don't worry. I'm not going to give you any antivirals for 3 days. And on the 4th day, if there is escalating fever, escalating cough, you give antivirals on the 4th day. I'm very, very strongly in favor of starting 4th day antivirals in a non-responding or escalating fever with comorbidities on the 4th day. So this, if we can, since there is no protocol, right? We do not have protocols to how to manage fevers after 72 hours. I say consider 72 hours as the magic moment. Within 72 hours, if you are fine, you're fine. If you are even getting better, you are fine. If you're getting better, you may expect 2-3 more days. Like Dr. Avinash Phadke said, exceptions make the rule. So 72 hours is the rule. There will be exceptions. If the fever goes beyond 72 hours, you have to judge by comorbidities and the symptoms whether you want to start antivirals. If the symptoms like 102 fever is staying 102 on the 4th day, and if the cough is staying bad or worsening on the 4th day, you must start antivirals if the patient has significant comorbidities. If the comorbidity is not significant, one comorbidity is enough. If the comorbidity is not significant, if the patient is 35-year-old male who is without any comorbidities, not even obesity, then I would say wait. Push him to 1 more day and 1 more day. You have till 7 days to give remdesivir. And try to see that you give it as late as possible. And if you don't give remdesivir and if you miss the 7th day, and if the patient becomes hypoxic, if the patient is young and without comorbidities, if the patient does become hypoxic, they respond beautifully to steroids. Over therapy, over treatment is the bane of last 2 years. And I think that is one thing that we have to learn. Yes, sir.
would throw open the floor to all the panelists. Anybody wants to ask more questions, can you just raise your
Yes, sir.
hand?
Good afternoon, sir.
Yeah, Dr. Bushlani, go ahead.
Yeah. Sir, can I take my question now?
Yes.
Yes, ma'am.
Yeah. Good afternoon, sir. I have a couple of questions. One is a relatively non-controversial one, so we'll take that first. Is paracetamol was recommended at most of the centers last week when the teenagers were taking their vaccine, which is Covaxin. Whereas at the other center, I was specifically told it reduces the efficacy of the vaccine. Which of the, and there are certain reports mentioning that. What do you say, sir, on this?
So it does not reduce efficacy of the vaccine, and it does not is not necessary to take it. They dispense it. I think that some people dispense even some other things with paracetamol. I've seen three strips being given. You must tell the patient that accept the strips, don't consume them, and you may need paracetamol afterwards, which is fine, and take it SOS. So I think. Yeah, it's what the problem is. Such a basic thing has not been turned into a protocol. That is the problem.
Yes, sir.
We regret that. All through the pandemic, we have regretted that. Yeah.
Second question, sir, is that after the first dose of Covishield, I've known certain patients to have very serious, severe side effects. So, would you recommend a second dose or port to Covaxin, which is not allowed as yet?
Never take the second dose if the first dose has caused severe side effects. You can define severe side effects as you like, but if there have been severe side effects, there's no question of repeating. Even by giving steroids or paracetamol beforehand, do not give the second dose for if severe side effects. Okay, please don't. And I don't know what will you do with the vaccination certificate, but I think there is some provision where you can give an exemption letter to the patient. Do that. That's all you need to do.
Okay, thank you, sir.
Sir, one more thing I wanted to ask, that some common drugs which we use in diabetes, hypertension and all, and their interactions with molnupiravir, because it is showing high interaction rate with many drugs.
Frankly, I don't know molnupiravir drug interactions. I know Paxlovid has several drug interactions through the cytochrome P450, but molnupiravir I'm not sure about. I would say, again, I'm repeating myself, but molnupiravir is a useless drug, should be thrown into the dustbin, and I think it will be thrown very soon.
Sir, one more thing for Dr. Phadke, sir, that is it true that during this Omicron, the neutrophil lymphocyte ratio is less altered as compared to the previous Delta?
Yeah, absolutely. Earlier, lymphocyte where you were getting lymphocytes count less than 10% in almost all the patients. And now you will see the blood reports, the lymphocytes counts are well above 20-25%. So the lymphocyte suppression is much less in Omicron. You are absolutely right. Even the elevations in C-reactive protein, which were in hundreds, you are seeing levels like 10 or 6 or 8, but never in hundreds in most of the patients.
Rushin, you want a question?
I want to ask one question.
Yeah, please go ahead.
Yeah. So, Dr. Tushar sir, if the patient comes only with runny nose, there are no constitutional symptoms, no fever, nothing, 2 days have already passed, still COVID test should be done, just running nose, and he is not a known case of allergic rhinitis.
So if there is contact, you would know that this is COVID, right? And currently we will probably get some contact or the other in almost all cases of runny nose or that. However, if you're still not sure whether you want to test, just consider this. By testing the patient, you are actually giving the patient freedom. The freedom to move around more easily, to do less aggressive masking in closed spaces, to not take the booster. That freedom is very important. And I would love that freedom.
Agreed. Thank you.
Sir, I have a question.
Go ahead.
Go ahead.
Sorry, thank you. Dr. Tushar Shah and Dr. Phadke, thank you for having us here. I'm going to ask two questions today. One is to Dr. Phadke, if he's still available. One was a light on the T-cell activity of the antibodies. Most of the patients keep on asking for antibody checks prior to taking the vaccine. We have two answers today, one by Dr. Tushar Shah and by Dr. Udwadia, having slightly opposite understandings on the antibody check before we take the booster. But we all know that the T-cell antibody response is something which is protecting us in inverted commas towards the newer variants or things like that. So is there any testing available, even not in the general public, but in their background about T cells? Does it actually make a difference of having the T cells on the background as well? Would be a question before we even discuss boosters option. And second one to Dr. Tushar Shah was, in the light of taking a monoclonal antibody taken for a patient, not as knowing if it's Omicron or Delta, but the patient still not responding 48 hours with fever, would it be prudent to discuss thinking of remdesivir versus molnupiravir, or of course not molnupiravir, now you're quite clear not using that, but would remdesivir be an important drug to think about, and etc. Thank you so much for taking my questions.
Dr. Phadke, about the antibody testing.
About the T cell response, it's a very important component of your immune response. At the moment, there is a test available, but it has remained a research tool. The principle is simple. The patient's blood is exposed to COVID antigen, and the gamma interferon, which is produced by the T cell, is measured. The problem is the virus has undergone a mutation. So this test was developed at the time of Delta. By then now we are landing up with Omicron. So that same test, the response could be altered on exposure to previous antigen than the current spike protein changes which have happened in Omicron make it unsuitable for routine use. And that's the reason you are not seeing laboratory generating report of T cell response in the current epidemic. But these tests are available. The problem is same like vaccination, that the tests will keep on evolving and changing.
About the question that you had for me, but first of all, the clarification. Dr. Zarir and my opinion on antibodies is not different, because he was talking about testing for spike protein antibodies before giving the monoclonal antibody cocktail or about breakthrough infection. What I'm talking about is whether you have had Omicron currently or not, asymptomatic, whether you can test it by doing nucleocapsid antibodies, which would be relevant in those who have taken Covishield, and therefore confirming that you had Omicron, and then deciding not to take the booster is my opinion. What was your second question? I forgot. Your question on monoclonal antibodies versus remdesivir.
No, sir, monoclonal antibodies given and then not breaking better because we do not know if the person had whichever variant.
So I think it's a relevant question, and many GPs would want to know, can I just empirically give without knowing Omicron Delta monoclonal antibodies? What is the harm? And thereafter, if the patient does not respond, go ahead with remdesivir. Fair enough. My only area of concern that I think Dr. Kumar also has a lot of study on that is there is something called antibody dependent enhancement, which means the antibodies can actually harm us in some situations. Meaning that if you already have antibodies, you have vaccinated, and now you're taking an antibody cocktail, which actually, of course, may benefit by its antiviral activity, may harm by causing hyperimmune response and worsening your pneumonia. We have seen some patients coming back with higher pneumonia and hypoxia after the cocktail. Now, I have asked Nanavati Hospital, Dr. Abdul Ansari, Dr. Patkar, I have asked Leelavati, Dr. Vasant Nagekar, Dr. Prabhu Desai, I have asked them to see how many patients are admitted after taking the antibody cocktail in a relatively stable situation. And we are trying to muster figures, but I must tell you that the Nanavati Hospital, which used to give 55 to 70 cocktails every day, has come down to 10 to 15 cocktails every day. Kokilaben has probably stopped giving cocktails. Leelavati will probably follow suit. Bridge Candy, of course, has given a lot of cocktails because South Mumbai, more affording area, etc. But I think they are reducing significantly the use of cocktails. When we say 85% Omicron in Mumbai, we are saying 85% on 9th of January, which was less on 1st of January. We are going to see Omicron becoming nearly 100% in Mumbai, at least within a few days. And when that happens, that is when at least that is when we should stop the cocktail. And I'm hoping that the task force goes against the cocktail once 100% is there. Otherwise, for 15% you want to take a chance, you do that. But I'm still against it. I'm still strongly against the cocktail when remdesivir is an option as an antiviral therapy.
Sir, I had a question. Sir, in a rapid antigen test positive person who is asymptomatic, suppose if he develops fever after day 3 or 4, then the day of illness is regarded as from the day of fever or from the day of rapid antigen test positive.
That's a very interesting situation that is happening currently because contacts are being tested rapidly. And initially, we used to have RT-PCR done much after symptoms, initially Delta wave. And therefore, first day was obviously the first day of symptom. Now, what do we call the first day? I still think that the first day of symptom, because the transmissibility obviously increases after symptoms develop. I think first day of symptom should be considered as the first day for the calculation of isolation.
Can I ask something? Sir, nowadays, everything, whatever I'm seeing in clinic, they are turning out to be Omicron only. I saw a patient with the joint pains. I saw a patient with the itching. I saw small number of patients with the diarrhea. So what are your views on it? Joint pains, diarrhea, are other symptoms which you are finding besides upper respiratory tract infection?
So the funny thing is this. Currently, I have 3 hospital admissions. One is a congestive cardiac failure with a high NT-proBNP of 11,000, ischemic cardiomyopathy. One is an acute cholecystitis, and one is a severe GI hemorrhage. 3 admissions. All 3 are swab positive. I can't say that the Omicron has caused the myocardial infarction or the gastroenteritis or the cholecystitis. So you will now increasingly see incidental Omicron positivity. The very fact that you did in joint pains means that the patient probably had some fever. Now you will miss the actual cause of fever. And therefore the rapid antigen test or the Rtpcr, this is what I would call a false positive rapid antigen test. We don't get false positive. It's 99% true positive. But this is what I would call incidental Rtpcr positive or false positive for the clinical sense. The patient does not have COVID clinically, symptomatically. Patient has typhoid, malaria. And all probably hospitals are treating their patients of everything, including angioplasty, bypass, to COVID hospitals because they don't keep. Now that has to change. We have to accept COVID swab positive cases in all hospitals. Otherwise, where will the beds come from? And that is another reason why Leelavati and Nanavati are full, because people are being transferred from non-COVID hospitals to COVID hospitals because of incidental Omicron swab positivity. Dr. Sunita, unmute. Is your husband around? Okay.
So can we say that COVID is worsening a pre-existing condition? Like you said that you have a patient admitted with cardiac failure. So he was a patient with ischemic heart disease and COVID worsened his status, or he has some amount of gallbladder thing. And so can we say that a pre-existing condition is worsened by once a person gets COVID?
If a person comes with congestive cardiac failure and also has COVID symptoms, then I would maybe think whether that COVID has aggravated. But what we are getting is person with systemic disease coming for that systemic disease, but not having any COVID symptoms like fever or upper respiratory tract. Those, how can I say congestive cardiac failure has been aggravated because of the swab positive when the patient is afebrile? So I don't think COVID will do that. In fact, we used to see that Delta diabetes and blood pressure were worsened by the Delta infection. I'm not so sure about Omicron. Omicron actually is behaving like a Darwinian virus. In Darwin's theory, the survival is of the person, the species, which can transmit the most without killing. If you kill your host, the host that you are surviving on, you will obviously kill yourself. That is a Darwin's principle. So why the virus is doing that? It is not killing or trying not to kill at least. and it's just infecting. Yeah.
Thank you.
There are quite a few questions on NSAID's use in COVID.
Yeah. So I was anti-NSAID till the Delta wave. Now with the severe throat pain that is occurring in Omicron, severe throat pain, meaning severe viral tonsillopharyngitis, you can see the redness. And that, in fact, two things about the tonsillopharyngitis. One is the severity is such patients cannot swallow, they cannot talk, they become hoarse. That has to be managed with NSAIDs. That I'm fairly certain we need NSAIDs for that. And I don't worry so much about the side effects of NSAIDs in Omicron as in Delta, because Delta was a viremia affecting multiple organs, including the heart, and therefore I would not like to give NSAIDs. But here, NSAIDs can be used. In fact, if you replace paracetamol with round-the-clock NSAIDs in patients with severe tonsillopharyngitis, I would be happy. I use naproxen very commonly. I use ibuprofen very commonly now. Also, I tell them to use paracetamol, but use NSAID as an SOS medication if you have severe throat pain. That can be done. So NSAID, I'm in favor of currently. And the second thing about NSAIDs is that, what is the second thing? Yeah, take care of the patients who are cardiac, who are renal patients, who are hypertensives. Teach them that NSAIDs are not good for you, and therefore and about the throat thing, also I have started using betadine gargles, and I'm proposing to start using some form of inhaled steroid, hopefully once I get my head around it. Yeah.
Sir, one question. Which antihistaminic will you prefer for the running nose?
So for rhinitis, viral rhinitis, we know that allergic rhinitis and viral rhinitis require different medications. Viral rhinitis requires first generation antihistamines. For example, CPM or Avil, or we have now dextromethorphan. Sorry, what is that called?
Dextromethorphan.
CPM, deschlorphenurmin maleate.
Yes.
That is, Polaramine is a brand name. That is first generation. The second generation is loratadine, cetirizine, fexofenadine is second generation. Second generation is not as effective as the first generation. So for example, my favorite brand is Polaramine. 2 milligrams is equal to 5 milligrams of Avil. You have CPM as dispensed drug in family practice. I use the first generation, knowing that it can cause drowsiness more than Allegra will cause. Second generation, I use less. First generation better, and also I use nasal sprays for patients with significant nose block, Otrivin or xylometazoline, oxymetazoline, and patients with significant sneezing, runny nose. I might use a combination of azilastine and steroid, so inhaled azilastine and steroid, like Dionase, etc. So we are still playing with the medicines in terms of symptomatic therapy. I do know that many family physicians, especially in Gujarat, have started giving steroids in the first week itself, in the first day itself, sorry, and that risk you should not take.
There's another point about betadine gargles. I find that a lot of patients start using betadine gargles and they're using it neat. They actually come back with chemical.
Yeah. Okay. Interesting question. Again, an area of unlearning that I'm exploring. You know, this has been Omicron has been a speed unlearning program where you have to unlearn so many things about investigations, about isolation, about treatment, everything. So I have always advocated from the first day of the first wave that gargling and steam should be completely avoided so that you don't disseminate as an aerosol. Of course, WHO came out with the aerosol recommendations much, much later, but common sense tells us that you will be spreading the virus across the house. In Omicron, I am wondering what to do. Steam would give, gargles would give relief. Betadine gargles, diluted, of course, would give relief. Some people advocate Disprin gargles, which is an anti-inflammatory. Not so sure about that, but gargles would give relief, I think, is correct. And gargling in an isolated bathroom with an exhaust fan on is what I recommend. Gargle, steam in your bathroom, personal bathroom with an exhaust. Of course, that cannot be done in a hutment where 6 people stay together, and therefore they can do it there. What is the harm? Will spread the virus across. Is that a harm? if you spread a low volume virus, I think it's a good thing. I'm shameless, but I think it's a good thing.
So what are your views on antibiotic? I'm very sure, and honestly, I'm saying I'm not at all using it. And those non-steroidal anti-inflammatory drugs are working wonder for the throat pain. But
Correct.
there are few, my colleagues, they are saying, Neeta, you're not covering for the secondary infection. Other few smart patients, they are coming, वो box वाली दवाई मैंने augmentin तो शुरू कर दी है, अभी डॉक्टर मैं क्या करूँ? So what are your views on it?
So two things. One is you stay steadfast. You don't budge. All those who do not believe in antibiotics should continue not believing in antibiotics. All those who believe in antibiotics may or may not be converted by you. That is, but I am telling you this from the experience that I have with laypersons, because I teach laypersons on groups, and the laypersons have started saying no to antibiotics. And that is one big thing that is happening. People are saying, why antibiotics? They are asking questions. And I'm very happy about that. I get a lot of flack from some doctors who say, okay, so what are you giving for treatment? You know, that is the question. Ab to agar antibiotic de to tum de kya rahe ho? Paracetamol khali de rahe ho. So that is something that we have to face. We have to face the flack. Also, we realize that there are 10,000 allopaths in Mumbai who are qualified allopaths, probably as GPs. And there are 90,000 allopathy practitioners over and above the 10,000. And it has been very, very difficult to make them unlearn, because they have been doing that for years. And their ball pens write azithromycin, their minds don't write azithromycin. So I think we can excuse them. Also, what has happened is azithromycin has become very, very kind of in the news that nahi dena chahiye. And now pulmonologists have started writing clarithromycin in place of azithromycin for this. And it is so upsetting to see pulmonologists who have Zarir Udwadia as their benchmark. So upsetting to see those pulmonologists, intensivists, MD physicians writing antibiotics. Or it is, molnupiravir ko excuse kar denge, lekin clarithromycin ko nahi excuse karenge. That is something that we have to. Yes, Dr. Jawahar, you had some comment.
We need to remember William Osler. He said one of the first duties of the physician is to educate the masses not to take medicine.
Wow.
We need to keep reminding ourselves of William Osler.
Another thing that Dr. Udwadia Senior likes of William Osler is a young physician writes 10 medicines for one disease. A senior physician writes one medicine for 10 diseases. What a beautiful concept.
Osler, again, if I were to quote, he said, it is much more important to know what patient has a disease than what sort of a disease a patient has.
Wow. Fantastic. So, yeah. I don't know what time are we. We have 10 minutes at least, I think. Or you want to wind up.
Any further questions from
Dr.
the panel?
Janak Shah has been quiet, yeah.
Yeah. So role of vitamin D in COVID or Omicron now.
Okay, so I believe Dr. Kumar has read more papers than I have read about vitamin D, but I will tell you what we have read, at least. Vitamin D observational studies, and then now there are some trials. Observational studies, I think I'm very, very convinced that vitamin D good levels keep the infection severity down in Delta. Of course, I don't know, I don't have data on Omicron. So they kept the infection. So my recommendation, we have to give some placebo. Remember that. We have to give some placebo over and above paracetamol. And you have to choose your placebo correctly. Use a placebo which is useful. So vitamin D is useful. Vitamin D is useful because we get less sunlight, because we are in the house more, in the office more, we are isolated. Vitamin D is an easy placebo to give, a useful placebo. Yeah. So I think vitamin D. I give a combination of active vitamin D and inactive vitamin D, so that because the inactive vitamin D takes about 5 to 10 days to become converted to the 125 dihydroxy. So I would give inactive and active together. Active is expensive, so you can get away with just giving the inactive form on a regular basis. But most of my patients have been taught to take 60,000 units per month, lifelong.
I think there are a lot of questions on isolation. When husband and wife both get the COVID and one gets it 5 days after the other, what is the isolation period for both?
this is a tricky question. Obviously, what I recommend is this. If the first person's isolation ends and the second person's isolation has not ended, the first person moves out with masking. The second person stays inside and moves out afterward. About masking within the house, I recommend that after 7 days, keep on masking for about 3-4 more days when in the presence of very senior people, like 75-year-old grandmother, for example. Continue masking within the house in front of senior people. It may or may not be useful, but at least it'll keep the viral load down. Our whole aim, we have to start focusing on ways to reduce viral load, not ways to prevent Omicron. Yeah.
Sir, here I always tell my patients that you have to use logic and logistics. Every household has a different logistics they have to manage. I cannot advise the same thing when they are staying 6 people in 1 BHK and there are one person staying in 6 BHK. So these are all different rules. So logic and logistics has to be mentally, and the doctor should be able to guide him better that way.
Another suggestion. Sorry.
Yeah, sorry.
Another suggestion that I have is in people who say कि हमारे पास एक ही common bathroom है, हम लोग 6 जन हैं. What do? I tell them use the bathroom, common bathroom. Mask while you are on the pot, for example, but otherwise unmask while you're bathing, you're brushing. Don't admit patients for isolation purposes now. 0 admission should be there for isolation, like we used to have so many. Yeah, Dr. Janak.
Yeah, sir, one doctor has asked me about the role of ivermectin. I know I don't use it, but this is a question asked. So don't fire at me after that.
Okay, no, there is no provocation here. Even if you mention the Vidal test, I will not be provoked. Yeah, so ivermectin again, studies after studies after studies, which are bad after bad studies, have shown that there is some role. We have analyzed, Kumar, myself, another colleague of mine, we have analyzed ivermectin to the bone, to the bone marrow, and we have tried to find some hope, some ray of hope in that molecule, because it is easily available, because it's cheap, but even as a placebo, we did not like it. Imagine, not even as a placebo we liked it, let alone as a cure or preventive. So no role of ivermectin. Kumar has some comment on ivermectin. Kumar is very passionate about it.
No, sir. Useless.
Okay. Useless. I know. And sometimes harmful. So we again, I think, see, the unlearning process in COVID has been faster than unlearning in any other disease, even though if it has not been adequate. HCQ, we unlearned fairly quickly, in a few months, of course, but still relatively very quickly. We will unlearn, almost doxycycline is almost gone, azithromycin will go, and ivermectin will take some more time, but everything will be unlearned. Favipiravir, now nobody mentioned favipiravir. Did you see Dr. Zarir mention favipiravir when he spoke about molnupiravir? Why did he not mention favipiravir? It is unlearned. We have unlearned favipiravir. I have used favipiravir so commonly. I've unlearned it. We have the process going on of unlearning. Yeah.
Sir, one senior GP from Kandivali, I don't know what is this, he has asked, what is NDD2G powder?
Yeah. This was another medicine invented by some army side, and recommended by ICMR. D2G or something like that. It was an antiviral proposed, and it came, and I think it had stillbirth, if not an early death. That stillbirth, and it is 2DG. I don't know what it's called, but it was a funny molecule. Yeah.
So
deoxyglucose. Yeah. Sorry.
Other day I had a patient who was in denial phase. He said, it is raining, that's why I've got cough cold. I don't have a COVID. His home Rtpcr rapid antigen test came positive. And he said, no, I don't believe it. And next day he did it Rtpcr, which came negative. Which came negative. So what are your...
So all these things will keep on happening. The person who collects the swab might be in a bad mood and might not do it properly or whatever. I don't know what happens. But the point is this. People in denial will not come out of denial. That I have learned through experience in life, in medicine and not in medicine also. So people who stay in denial will stay in denial. what I do sometimes is to provoke them. Okay, you don't have COVID, so please sit with your grandmother and listen to her stories and tell your stories to your grandmother, and he will not do it. That will show him what a hypocrite he is as a denier. Janak Shah.
Yeah, so one more question. Cough in COVID may be due to GERD. And should we stop PPIs?
I did not understand the question. You said if it is due to GERD, that is
GERD.
reflux.
Reflux. So shall we stop PPI during that time or what?
I think what I understand from your question is the patient has GERD, has been taking PPIs, and now has gotten COVID. Should we stop PPI? Why should you stop? Why would you stop?
The cough, because of GERD, there is a cough. So how this means the cough will remain. And
sir, I think COVID patients will be easily able to recognize a new cough separate from their GERD, and this cough usually is associated with a lot of that kind of thing, and a lot of throat pain. So I think, and sometimes hoarseness. So I think COVID-related throat symptoms have become fairly distinctive and should not be missed.
There was some reports about PPIs not being as good as famotidine in this case, where famotidine was better in COVID patients.
So famotidine has been proposed as an antiviral drug early in the course, and this dose of famotidine was intravenous and a very high dose. Again, a repurposed drug of no utility, I think. So, but yeah, if you kind of want to add on some placebo effect to yourself, sometimes doctors give placebos to themselves by giving something that they've read about. So I think that can be done. So,
okay,
Dr. Jawahar, I would like to ask you, Dr. Jawahar, because all of you are very sensible physicians. What do you do for the throat symptoms?
Benadryl.
Sorry?
Benadryl.
So paracetamol of course helps. I have also, for some patients who had intractable pain and burning sensation in the throat, I have actually asked them to slow sip on mucin gel, and I found that very good.
Oh, wow. Dr. Anil, any suggestions for the throat symptoms? Because we are lost.
No, I mean the codeine-based expectorants are not easily available, so it becomes difficult. But the lozenges, the Alex lozenges, will do the same trick, and it works.
Dextromethorphan as a syrup or lozenge. Dr. Kamlesh, any suggestions there?
What Jawahar told, I have been giving this mucin gel with good benefit.
Yeah. Okay. Okay.
Sir, now we come to Elaine.
One last question, sir. The children vaccination have started, and then incidentally, the child is found to be, after vaccination, he found to be having fever and cough cold, and RAT was positive. So whether it will have some detrimental effect on the child health when he has taken Covaxin, he got it now Omicron or whatever.
No, I don't think there'll be a detrimental effect. Covaxin followed by immediate infection. We saw a lot of Delta from vaccination centers, if you remember that. And I don't think we saw any detrimental effect of the vaccine because the patient had Delta. So no, there won't be. The more interesting part is school-going children, if they get Omicron, should they take the vaccine is the more interesting question. And my opinion is that they should not. But the Indian Association of Pediatrics has recommended strongly, whether or not you have had COVID, you must vaccinate your child. I think the unlearning here is we are all in the Delta mindset. We have to come into the Omicron mindset and behave as if this is an influenza-like illness rather than a Delta-like illness.
I think one of the last questions I think we should have is immune boosters and vitamin role.
Many doctors passionately believe in immune boosters and various things. I don't even know them because I don't prescribe them, but coenzyme Q10 or whatever, I don't know. I don't believe in them. I think good nutrition and exercise is the best immune booster that you can have. And if you can have that, there is no need for any boosters. But I would like your opinion because I have never prescribed any immune boosters.
Because lots of patients will keep guzzling out. They're started on vitamin C and zinc since the beginning of the pandemic and are still on it.
So that I have learned that that's a good placebo. any vitamin that is containing C and zinc. For example, I give a brand which has zinc, C and B complex. Any vitamin which has zinc, and because they will ask you, मेरे को zinc नहीं दिया, मेरे को vitamin C नहीं दिया. So I give. I don't want the question because they are harmless and they're great placebos. So yeah, I think we would give. The evidence for zinc, the evidence for C is not good. Like the evidence for D is reasonably good. There is no evidence for zinc and C, which we have been convinced by.
The last question. Should we get booster even if we may have a symptomatic COVID?
If you have had COVID in Omicron era, asymptomatic or symptomatic, my suggestion against the grain of advice is not to take the booster. Right? When Dr. Zarir showed the slide where there is the 20% protection from 2 doses against Omicron increases to say 50% in Covishield and 70% in Pfizer. What one more thing should be added to that is what is the duration of that protection from the booster? The duration is small. It is 3 months. If the duration of the booster is small, how many boosters are you going to take? And for what disease? You are talking about Omicron. You're not talking about Delta. Protection against Omicron with, and in the same breath, Dr. Avinash Phadke does tell us that T-cell immunity is there after 2 doses. And that will keep your disease mild. So I believe 2 doses are good for Omicron. 3 doses are necessary for Delta. And the boosters that we take for Omicron will be only because they are mandatory. If they become mandatory as 3rd dose, which they will not become mandatory, I'm sure of that. So I think take boosters if you have significant comorbidity, so that at least 3 more months of protection you get. But I think if you don't have comorbidity, you are young in age, I would avoid boosters.
Okay, the last question is the flaming question here. Is this the last flicker of the flame?
No, not at all. Not at all the last flicker of the flame. We family physicians are going to be taxed for another, I don't know, several months, maybe several years. But I hope it is the intensity of our work, because we'll all be fatigued. Intensity of our work should not remain the same. I'm just hoping that, but I can't promise. No, nobody can promise that. So no, it is not the end of the beginning. It is still the continuation of the beginning.
Okay. Anil, anything else?
No, we can vote of thanks.
Rushin, can you please come forward and give the vote of thanks for the...
At the end of this great session, I would just like to say one line. That yes, though it's not the end of the beginning, but at the end of something is always beginning of a new thing. And that's something we all need to remember and take home as a message. I would eminently thank Dr. Zarir Udwadia and Dr. Tushar Shah for this wonderful session that they've chaired. It was a great experience, a lot of learning for all of us, including the public who might have tuned in. And there's no words to thank you for the time that you all have spent and the inputs and your medical expertise, and to put yourself out there to give information which could be controversial or could be discussed and taken upon you on your word is something great only stalwarts can do. So thank you so much for that. I would eminently thank Dr. Avinash Phadke, sir, to be here with us. He is a beacon of hope in the pathology world. He has been a great teacher to us. I was a student under him for a while, and he has been an amazing person. And I thank him so much dearly to come and be a part of us at this last moment. All the panelists, great questions, great interactions, kept Dr. Tushar Shah on his edge. I think till the end, he was scratching for a bit of answers to come up with to give wiser information of Dr. Kamlesh Shah, Dr. Asha Vasani, Dr. Anil Mehta, Dr. Jawad Mukhtiar, Dr. Vijay Khambati and K. Kumar, Dr. Nisha Khuslani, Dr. Manoj Malkan, Dr. Janak Shah, Dr. Sunita Manglik, and Dr. Meeta Dhala. Thank you so much for all the time that you spent today in the morning. And finally, not the least, I would like to thank the entire organizing team, the Bombay Seaboard Medical Association, the Bombay Medical Union, the Suraj and Reliance Foundation Hospital, the GPA, the FFP API, the JDF, the AWARD, and the Bombay DWAD Medical Association. To all the viewers and listeners for this entire program, thank you so much for joining us and making this a grand success. This will be the links are already shared. I'm pretty sure this could be on for you all to view at a little later date. If there are any further questions, I'm pretty sure we will be able to forward them to Dr. Tushar Shah at some point and get a few answers from him if he obliges us in the future. Thank you so much, and I hope to have a greater session next month. Thank you for listening. Goodbye.
Thank you, sir. Thank you so much.
Thank you.